25, let's start. Yeah.
Good morning. We're happy to have everyone here for another fantastic session in POSI. We've had 2 exciting days. I think we have a busy schedule for the morning, and so that we can stick to time, we'll start with our first video, and then I'll hand over to Dr. Jayant for the rest of the proceedings. Can we have the first video playing, please?
Hello and good morning. My name is Abhay, and it's a great pleasure and privilege to be part of your meeting today. I work in Melbourne, in Australia, at the Children's Hospital, where we celebrated our 150th birthday recently. So that was a great occasion, and I have the privilege of working with a wonderful team. People you might have met or known, and it's always a good thing to acknowledge all their contributions. I'll start with some fundamentals to keep in mind. Know where the brain pathology is in cerebral palsy. We know that this is a non-progressive brain disturbance, but the musculoskeletal problems are progressive and secondary. The effect of the brain lesion is both positive features and negative features that affect the child in structure, function, growth, and activities, and society in multiple other aspects. The natural history of cerebral palsy follows the trajectory of growth and the trajectory of function, all of which is intertwined. Living with CP is a lifelong prospect, and a child with CP will grow up to be an adult with CP. Having got that out of the way, what's our approach? Our approach is mostly preventative maintenance to work with the natural history so that the outcomes are as good as we can get them. Timing is everything, because the musculoskeletal changes are progressive, and following the gross motor curves and treating it at appropriate intervals is really important, especially because the musculoskeletal pathology worsens with time. To get on the same page with this, these are the 4 things we'd like to know for every person or we see with cerebral palsy in relation to where they are on their gross motor curves, using the GMFCS as the starting point. And that allows us to identify what our goals are for levels 1, 2, and 3, and levels 4 and 5. So when we come down to the source itself, who needs surgery? This is a muscle that has a complex function, both in stance and in swing. And when it doesn't work, it causes problems in stance with incomplete hip extension. But what I must emphasize is that the effects are both upstream and downstream. So it's not just a local effect on the hip joint, but both in the trunk and in the knee and foot. In the non-ambulant population, it affects sitting balance and the displacement and function of the hip joint. The clinical scenarios here in the ambulant children are gait features, knowing what the Thomas test identifies, and specific kinematic features, not just at the pelvis and hip, but at the knee and down by the foot and ankle as well. In the non-ambulant children, it's the sitting posture, supine examination to identify the FFD, and radiology as well. So based on this, we will work towards a decision-making algorithm, and this one follows a typical diagnostic matrix pathway where we look at the list of impairments by each level: the hip, pelvis, knee, foot and ankle, and trunk. We look at the severity. We look at and identify whether they are primary, secondary, or compensations. And based on that, you will then identify goals of treatment. So in the ambulant children, our primary goal is getting sagittal balance. This is the key to establishing long-term gait function, to increase hip extension and stance phase efficiency, and secondary goal is swing phase efficiency. In the non-ambulant children, hip joint function is the key, release of contractures, and effect on hip displacement. The technique in the ambulant population is at the lengthening at the muscular tenderness level. This is above the pelvic brim, not at the lesser trochanter, and part of multi-level correction. In the non-ambulant children, it can be at the lesser trochanter, but just watch out for heterotopic ossification, which is a specific complication here. The outcomes are mixed. Eric Rutz presented this a few years ago, where he said that distal lever correction is very important, and that if you get the knee and the foot and ankle right, then the hip deformity can improve by itself, and that's important to remember. Malay, in his study, also said the same thing, that if you continue to just work only on the source but forget everything else, you may not see as much improvement in gait, but you may see some improvement in specific knee and hip positions. The group from Gillette presented and published multiple outcomes, but even they recommend that you can see changes in hip and pelvic position, but the impact on gait is limited, and they recommended using the hip flexor index to quantify that process. And in non-ambulant populations, Miller's study says that the effect is dependent on the severity of hip displacement and the length of follow-up. And our study from Melbourne said pretty much the same thing, is that the effect of source lengthening just depends on your GMFCS level rather than the source lengthening itself. So in conclusion, is it an outdated operation? No, it's just part of a toolkit. And when do you use it? As part of multi-level surgery in ambulant patients, and as part of restoring hip range of motion in surgery for hip displacement. Thank you very much.
Thank you very much, Abhay. That was an excellent roundup and the perfect start to our CP session. We've got 10 minutes for questions at the end, and I think all the speakers have are to time. So we will move on to another important problem, which is equinovirus for deformity and decision making. We can run the second video, please.
So this is the second talk that I'm happy to share my thoughts with you about treating the equinovarus foot. But there's a couple of things just to be aware of, that for upright mobility, these features suggested by Jim Gage are absolutely vital to know, as is the biomechanical basis for the way we walk with a base of support, center of mass, the moments around the joints, and our control. So when you look at the equinovarus foot itself, it is the result of a combination of factors from upstream, both loss of inhibition and loss of connections. And the effect is in the stance phase for gait, instability of the limb and the trunk, the position of initial contact, the inability to progress through the foot and ankle motion through stance, push-off being compromised, and abnormal overload of the lateral column. In the swing phase, it leads to problems with clearance of the foot, repositioning with a lot of proximal compensation. So a small problem around the foot and ankle with multiple effects. In the non-ambulant population, positioning can be difficult. There be problems with standing for transfers and pressure areas, all of which are intricately related to AFO intolerance. To look at the deformity itself, it affects different segments in the ankle and foot, descriptors as seen here, and the effects on the weight-bearing surface can also be identified. The contributions are distributed. 1/3 tibialis anterior, 1/3 tibialis posterior, and 1/3 of patients have both tibialis anterior and tibialis posterior contributions. So just keep this in mind when you decide treatment. When we evaluate this problem, this is a typical sequence to follow, and specifically related to this is the Coleman block test, and we can use special investigations as speedobarography, EMG, and sometimes CT. The decision matrix follows a typical pathway, age and GMFCS level 1, 2, and 3, primarily for function and gait, both in the stance phase and in the swing phase. Brace tolerance is important in these children, and for level 4 GMFCS, the ability to have a stable foot for standing transfers, and level 5 positioning and comfort. So this gets you onto the right kind of treatment and assessment plan. Tone management is mostly for spasticity and to identify dystonia and whether it's a mixed tone problem. Flexibility of the foot is important, also to know whether muscles can be selectively activated, to look at passive corrigibility of each segment in the foot, the Coleman block test as a functional test, and joint range of motion, which is really clear to identify because it's a surrogate for muscle contracture that we use. To look at brace tolerance is also important. The maturity of the foot in relation to growth suggests that the later in age that you see this problem, the more likely it is to be worse and eventually decompensated. The soft tissue elasticity is important to document because of the state of the skin and whether it will allow correction. The risk to neurovascular structures being stretched out of an equinovarus position, the capsular contractures at the joints at each level. Joint health as a specific thing relates to age and how long the deformity has persisted, the shape of the bones in the foot, joint alignment and shape, and the capsular and ligamentous integrity, all of which will determine the longevity of the joint in terms of its health. And translate that to the functional needs of the patient by GMFCS level, by the stage of severity of the equinovarus foot position, the complication profile associated with correction, and this of course is proportionate to the severity, the ability of the person to comply with our treatment plans, the rehabilitation potential, the duration of follow-up. So determining the treatment plan, you can use any or a combination of these options. For tone management, botulinum toxins generally the most commonly used, but some of these others have been described as well. Orthotics are a key pillar of management, both for control, for comfort, sometimes for correction, but more importantly for maintenance of foot and ankle posture and position. Muscle surgery is the bread and butter of orthopedics in this problem. The type of operation is directly linked to which muscles involved, and our main combination is the third one, which is both tibialis anterior and tibialis posterior. So for the tibialis posterior, we would recommend an intramuscular lengthening and a split lateral transfer for the tibialis anterior. The lateral transfer is not a good operation in this, mainly because of its tendency to overcorrect the foot. So our typical prescription is a appropriate calf lengthening at the level dictated by the severity of equinus, an intramuscular lengthening of tibialis posterior, and a split anterior tibial transfer where the splits attach to peroneus brevis. When you do need to do bony surgery, it's for fixed deformity, but after achieving muscle balance. And for fixed heel varus, a closing wedge osteotomy of the os calcis is recommended. Arthrodesis is for more severe deformities with poor joint health, and always remember to ensure that the forefoot's corrected as well to achieve this through a column surgery, like described by Evans, or a calcaneocuboid shortening fusion. In rare occasions, the telectomy can be a salvage operation, especially in the non-ambulant population. It helps with some of the skin issues by keeping the approach on the more accessible dorsal aspect, but you may still need to do some muscle surgery and ensure good bracing afterwards. So in summary, the treatment choice is individual, but with an algorithm, and long-term monitoring is the key. There are some outcome studies which show that the natural history tends to progress from varus to valgus, so it's better to wait till they're older, and early surgery is likely to lead to correction. This study was from our cohort at the children's, and we got the best results between ages 8 and 11. Similar study outcomes from a group in LA. So in conclusion, it's common in kids with hemiplegia. It causes significant morbidity and functional impairment. Careful evaluation is the key, and have a team approach to management. Titrate the surgical dose based on the severity and the functional goals, and have careful postoperative care, good orthotic supports, and careful monitoring for a longer term follow-up. Thank you very much.
Thank you so much for that, Abhay. I've just been informed by Dr. Dhiren that we have an extra 15 minutes for discussion, and we have 90 participants on a Sunday morning. So everyone's obviously interested. So we might actually finish off the questions. We have a lot of questions in the chat box. So Tushar wants to know, is the volume of psoas release coming down? Are we doing fewer psoas release for Abhay?
Yes, definitely. I think overall the clinical scenario that we see is catching them younger, keeping the distal levers functioning better. So the need to do psoas is much reduced now. I would say in my practice, I see more kids with hip extensor weakness than I see with a real psoas contracture. So I don't see the need to do it as often.
And Sandeep Patwardhan wants to know, does rectus release proximally have the same effect as a psoas release at the brim with respect to improving hip extension in ambulators?
No. The short answer is no, because the position of hip extension that you get in gait is more dependent on where your ground reaction vector is going rather than the actual muscle. So it's more a joint alignment thing rather than a muscle activation thing. Both psoas and the rectus are more effective in swing for achieving progression of the unsupported limb rather than the stance phase limb.
So, and well, we have many questions. Is there any role of Botox for the psoas in younger children, perhaps?
If you're good enough to give it and know where your Botox is going, then possibly, but I've never seen it work. Weakness is always a bigger issue than spasticity.
And would your level of release of the psoas differ with GMFCS level?
As I said, yes. Intramuscular for ambulant, Atlas trochanter permissible only in the non-ambulant.
And Molan wanted to know how do you decide the dose of, how do you decide whether it's a tibant or a tip post transfer you would do for equine varus deformity?
In our practice, we would vary. In fact, I remember only one tip post transfer that we've done, and that was really difficult. Our prescription, like I said, is equinus correction at the appropriate level, intramuscular tip post release, and a split tiband transfer to the peroneus brevis. So that's our standard prescription. So we don't vary from that unless more bony surgery is required.
When you consider peroneus longus to brevis transfer?
Not in the spastic equinovarus foot. The peroneus longus brevis is more in CMT and with a very careful muscle charting to know whether you can get correction with the peroneus longus brevis, which has got a smaller treatment effect. And if you need more in sensory motor neuropathies, then in that group, I will do an interosseous tibialis posterior transfer onto the dorsum of the foot to hold the foot up and stop its inverting effect. So different pathology, not CP.
So the main problem, as I understand it, with the post-split transfer is overcorrection, that they go off into too much valgus over time.
Yep. So, and overcorrection is harder to correct than undercorrection. Yeah, so as we know. Yeah.
Kishore, any comments?
No, I mean, I pretty much follow the kind of philosophy that I picked up, especially as it came to psoas, and we used to call Paulo the psoas Selber, and he would find a reason to do a psoas release and a lot more.
Yeah, long finger.
Right. That's right. And I think now when it comes to non-ambulant children, and I often take out psoas at the time of whether I'm doing a VDRO. I used to wait till I'm doing the VDRO, but when I'm doing the adductor release, I fish it out and take it out, because I find sometimes when you're deciding between trying to do an open reduction and not, doing the psoas through the adductor gives probably a better chance for you to reduce the hip. So even though it's a little bit more extensive incision for you to do that, the only pearl that I would tell people is, if you are doing a GMFCS 4 or 5 and you've got a rhymus migration percentage of 60 or 70, you're thinking about, do I need to do an open reduction? I would say through the medial wound, take the psoas off. Your chances are probably reducing a little bit better.
Can I ask a question, Jayant?
We will continue with the next talk, but Maulan, you can use the chat box, and I would ask the faculty also to monitor the conversation. There are plenty of questions in the chat box. I don't think I'll be able to ask the questions live. So if the faculty could just answer the questions as much as possible in the chat box. But we will use maximum time, and we will give screen time to all the delegates, because we do have some extra time. Next video.
Do you want us to use the chat box or the Q&A box? Because I think there's things coming up on both.
Oh, both.
Both. Okay.
Good morning, everyone. Greetings from Vancouver, Canada. Today, I'd like to talk about a 5-year-old child with rhymus migration percentage of 45% bilaterally. What do we do? Soft tissue release, varus irritation osteotomy, and how do we make those decisions? What factors can help us make the decision? One of the important considerations is really understanding this classification system. Higher the GMFCS level, more chance of hip displacement. In the GMFCS 5, your chance of hip displacement of more than 30% rhymus migration percentage is in the order of 90%. And the rate of hip displacement is higher as the GMFCS level increase. In a GMFCS 5, you have almost a 10% increase per year in some children. These are important considerations for monitoring and decision making. Adductor release success will depend on GMFCS level and also the percentage of migration when we've done the surgery. The lower the rhymus migration percentage and lower the GMFCS level, the chance of repeat surgery is lower. This study done from Melbourne shows that
there is a high rate for reoperations in GMCS 4s and 5. This survival analysis shows the chance of repeat surgery in GMFCS 2 is quite low. So again, to reiterate the points, the child is ambulatory, they're likely to have a good outcome. And GMCS 4 and 5 sometimes, the reason for doing adductor release is to buy time to delay reconstructive surgery. A good example is if I see a child that is 2 or 3 years of age, even if the ramus migration percentage is 60 or 70, because we do not have many implants that we could use in that age group to do varus rotation osteotomy, I often delay by doing a soft tissue surgery for about a year or 2 before I do bony surgery. For varus rotation osteotomy in a young child, the timing is often not clear. It's very surgeon dependent. Some important considerations may be age at surgery, preoperative migration percentage, GMFCS level, and surgeon expertise. Other factors are the rate of progression, bony changes, and pain, and more importantly, what are the wishes of the family in considering this surgery? This study, published in 2006, showed that the rate of repeat surgery is higher, both for soft tissue group as well as for varus rotation osteotomy. And these are not apples to apples for comparison. Sometimes the reason somebody gets a bony surgery at a young age is probably a severe disease to start with. But nonetheless, it's important when we counsel these families to say, this surgery we're doing in a young child, like a 5-year-old, is probably the first of few surgeries to come down the road. Dr. Unni Narayan from SickKids Toronto has put together a large study group to look at health outcomes in these children with cerebral palsy as measured by CP Child. Hopefully this study will answer a lot of questions about soft tissue versus bony surgery. If bony surgery, what is the dosage of surgery? Prophylactic versus reactive surgery, and contralateral surgery, whether it's indicated or not, if so, at what age we are going to do. So this study is going to have an important contributions for our understanding of cerebral palsy hip and its management in years to come. If you diagnose early, you have all of these options at your disposal. So it's really important for all of us, whether you're in a clinic setting, hospital setting, or if you're able to do a population level, either in your state or in the country, it's important to consider hip screening. I'm so glad to see all of the different societies in India working together to develop care pathway for India for cerebral palsy hip screening. Thank you very much.
Thank you very much, Kishore. I think in the AGBM yesterday, we made a brief introduction about the hip surveillance pathway that we are trying to introduce in India. And there is a meeting in July in Mumbai, which hopefully will happen, COVID permitting, which will allow us to draw up guidelines that are specific to India and also an action plan as to how a hip surveillance pathway can be introduced. And I think the main takeaway message for me from Kishore's talk is that early recognition and having some system in place to pick these kids up or at an early stage will save us a lot of hassles, both for the family and for us down the line. Kishore, any comments?
No, I think, kudos to, I think, the leadership from POSI and, working with, obviously, Dr. Johari and his team. So I think the future is bright in terms of how much time not many people would know people have spent on developing these guidelines. I think it's a tremendous amount of work through pandemic, giving up their valuable time participating in it, which I think is going to be a great first step in doing that. Just the discussion and awareness itself, we found in British Columbia, even before we had a formal implementation of a surveillance program, brought down the late presenting cerebral palsy hips. So I think that's great. Yeah, I mean, I think there is no right or wrong answer. It's really important to understand that there is no fixed way that we make a decision. It depends a lot on the anatomy of what we're seeing, the child, where the child is, how ready they are. As I mentioned in my talk, it's not uncommon sometimes I see a 3 or 4-year-old, even though ramus is higher, I've done adductor release, I put them in a splint till the bones are a little bit bigger. So I have the right kind of implant to do. I've seen a lot of disasters where trying to do big operations in young children with cerebral palsy. So you really have to see what equipment do you have available and what kind of follow-up you're going to get from a child before you're making those decisions to have soft tissue versus bony. I think there's a lot of other factors that go into it.
If I have one question to both Abhay and Kishore, does an early soft tissue release, for a higher GMFCS child with large migration percentage, does that burn our bridges down the line? Is it okay to do a soft tissue release? You can always do a bony reconstruction later. Is that a reasonable approach?
Yeah, I don't think it burns any bridges, but you should be prepared to re-release the contracture that develops again. So it might be a bit more challenging to understand what's a muscle versus, where your anterior branch of the obturator nerve is versus, fibrosis there is. So other than that, I don't think in my hands, I felt doing an adductor release before burnt any bridges for me later on if I had to do bony surgery. But what I certainly realized is either with soft tissue release or bony surgery, roughly 30 to 40% of them, when you've done younger, you are going to do repeat surgery. So it's very important to counsel the family to say, this is probably one of the many surgeries to come down the road. And we're trying to put this hip back in, and there is a good chance the hip will continue to come out and we need to monitor.
Yeah, if I could just say, it is very difficult to create a one prescription fits all protocol in this, because the phenotype of even a non-ambulant child who presents with a hip problem is extremely variable. And I think our approach is to start from a more global perspective and then narrow it down to what the hip actually needs. But that decision for the hip comes at the end of all the preceding steps, which is what does the child need? What's the natural history going to be like? And so we don't have a one rule that fits all at all in this area. We are running a RCT, a randomized trial at the moment for anyone between the ages of 4 and 10 who presents with both contracture and subluxation with an MP under 100, not over 100, so not a completely dislocated hip. And the RCT says adductors only or adductors plus bony surgery. And that's proving to be quite a challenge to have this dichotomy. But hopefully with the trial, when the trial ends and we go through the analysis, I'll be able to give you more feedback as to what might actually happen. The other challenge, which I'll reflect on in relation to what Kishore said, is that we have found that in younger children, using the Orthopaedics cannulated blade plates has allowed us to successfully bring hips back to normal, even in a child who's weighing 12 to 13 kilos. So the smaller implants have given us a lot more confidence that to be used in younger children, because if the hip's already dislocated by age 4 or 5, and they're in pain and they have difficulty with perineal care and comfort, then waiting till they're older is not making any sense. The fact that they're in pain means that an adductor release will not reduce the hip or relieve their symptoms. So you really have to then do enough to solve the problem at that particular time. So sometimes a privilege of waiting is not clinically possible.
Jayant, can I make a small comment?
Please go ahead.
Kishore, one of the issues what we face is, of course, surveillance and diagnosing a spastic hip disorder. But a greater problem is the lack of enthusiasm, which is seen in parents and therapists to treat a spastic hip disorder vis-a-vis a gait improving surgery. People are ready to immediately buy a gait improving surgery, but there is lesser enthusiasm among parents and therapists to buy a hip correction surgery. So, that's something which we are facing.
Yeah, I think you raise a really good point. I think, Taral, that's something to keep in mind is any screening or surveillance, its success only depends on if you have an intervention to do, we know we have, and there's the ability to actually secure that intervention, which in India is a challenge because there's so many factors go in to where the expertise is for that, and also if the family can afford it not. So yeah, screening is going to diagnose early for you, but you still need all these things, especially the challenge you said about the family willing to go through with the surgery and the rehab and other things that are required. You could potentially probably make them a lot worse and dealing with all the complications if they can't follow through with the treatment, which is really, really important consideration. As the screening goes in India, you will all start seeing a lot more patients coming your way, but that would come with its own challenges.
Thanks.
May I add one more point to help Taral with that approach? Yes. Is to consider treatment for hip displacement is a quality of life procedure, not a procedure to ensure normal hip growth and longevity of the hip into adult life, because those goals are somehow a little bit nebulous and they're not as easy to fulfill or reach. And then the quality of life issue is a much easier one to deal with.
Right.
So we'll go to Taral's talk, please. Please, could you run the next video?
So in next 7 minutes or so, I'm going to talk about foot and foot in cerebral palsy. I'm Taral Nagda from Bombay. So foot in cerebral palsy is necessarily a stance phase problem and affects walking in a child with cerebral palsy. And it should not be looked upon in isolation, but in conjunction with GMFCS and ICF. GMFCS because progression is dependent on GMFCS and the treatment depends on function of the patient. What causes it? Always starts with a child walking on toes, the spastic calf muscles. And as the child grows, the calf muscles get contracted and there is pressure on the forefoot, which causes midfoot break. And finally, the child ends up with a full-fledged palmopelvic deformity. When you look at the child with this deformity from back, it appears that the talar head is subluxated on medial and plantar direction, and it loses its coverage by navicular bone. The calcaneum is in valgus and has reduced pitch. The tibia goes in axial rotation. There is hallux valgus, and there is forefoot supination. So it's a lot of deformity when seen from top, front, and back. But it's also necessary to have a view from down under, look at the sole with help of podoscope, because that gives the real extent of the deformity, and examination is incomplete without having look at the sole from below. What the patient feels are two P's. First is prominence of the navicular tuberosity and pain, which often manifests as a brace intolerance. What we look at is a lever arm disorder, the disorder of the deformity of the foot causing the child difficulties in walking. And this is because of reduced lever arm dysfunction, which affects the ankle plantar flexion knee extension couple and this causes the pes planus to be a precursor of crouch gait in the child. The X-rays are weight-bearing views, where on an AP foot view, talometatarsal angle is calculated, and the subluxation of navicular over the talus is calculated. CT scan, though can give a three-dimensional assessment of the deformity, is not very useful because it cannot be done in a weight-bearing position. The management depends on level of function and ambulation, and the four corners of the treatment are tone management, orthosis, contracture management, and skeletal stabilization. The braces for flexible deformity, dynamic AFO, for moderate to severe planovalgus foot with crouch gait, a solid AFO. Older child, where you manage to get foot plantigrade after a surgery, ground reaction AFO works well. For a small group of patients with flexible planovalgus with good control over dorsiflexion and plantar flexion, SOMO will work. More denervation in calf and peroneal may help in younger children, where spasticity is a predominant issue and interferes with brace wearing. When there is gastrocnemius contracture, a judicious lengthening will help in very young children. The mainstay of treatment for a full-fledged deformity is a reconstructive surgery. It's very important to differentiate the two pathologies in a pes planus valgus and the surgery required for the two. The first is a hindfoot valgus, which requires stabilization of the hindfoot at the talocalcaneal joint. The second issue is imbalance between the medial column and the lateral column, which is restored by lengthening osteotomy of the calcaneum, which can be combined sometimes with a medial surgery in forms of soft tissue surgery plication or talonavicular fusion from the medial side. Associated surgeries may be required for treatment of hallux valgus and tibial rotational problems. So, variety of surgery is possible, and this article makes it very simple to select. In ambulatory children, calcaneal lengthening surgery will work. In non-ambulatory children with severe deformities, calcaneal lengthening surgery cannot work, but a fusion will help. So some of case examples here. This is a 6-year-old child, GFCS2. She had brace intolerance, the talus metatarsal angle almost 35 degrees. What do we do for the young child? So we chose a surgery called arthroresis, put a screw into the calcaneum and leave it a little proud so that the subtalar joint does not go into valgus. So this stabilizes the subtalar joint in an extraarticular fashion, allowing all the range of movements. And this patient, even after 4 years, the arch was maintained, the foot shape was maintained, and she retained her walking level, ambulatory level, without having to undergo any additional surgery. In contrast, this is a 10-year-old child with GMFCS3 with brace intolerance, pain on the medial side, and this patient requires a calcaneum lengthening osteotomy as described by Mosca without any medial surgery, and this patient did well after this surgery. GMFCS4 in a 10-year-old child, and where major problem is pain, callosities, and transfers. Now this patient, calcaneal osteotomy will not work. What it requires is medial and lateral surgery. So on the lateral aspect, a combination of subtalar fusion with a screw, with calcaneum lengthening, with a medial talonavicular fusion, and along with this fusion of the MP joint to treat hallux valgus and tibial derotation osteotomy. So with this cocktail of surgery, this patient had a foot which was helping the child for transfers. And on longer follow-up, you can see that he's able to walk barefoot within the house and uses AFO for going to his college. So in summary, clinical decision-making for management of foot deformities like this requires a diagnostic matrix, the clinical history, physical examination, X-rays, observational gait analysis, and 3D gait analysis. The foot deformities, which are dynamic in nature, can be treated by chemodenervation and orthosis. Those where there is a soft tissue contracture may require judicious muscle lengthening, but most of them require proper analysis of the deformity to correct the fixed bony deformities, and the surgeries which can be selected are either combination of lateral column lengthening plus or minus medial surgery, soft tissue or bony, plus or minus subtalar fusion. And if you treat the foot well, the child's walking potential can be improved. Thank you very much.
Thank you so much, Tarul. We'll take questions at the end because we're just about managing to keep up with the time. So Abhay will talk to us about unilateral hip subluxation in type 4 hemiplegics. And please do feel free to ask questions in the chat box.
Good morning. At the outset, I would like to thank the organizers for giving me this opportunity to speak on this topic. The question I will be discussing is unilateral hip subluxation in type 4 hemiplegia to operate on one or both hips, pros and cons, when and why. Essentially, this addresses decision-making in hip dysplasia and hemiplegic CP. The etiology of hip dysplasia and CP is well described. The natural history of hip dysplasia eventually leads to arthritis and a poor quality of life. The correlation with GMFCS is well documented, showing a linear increase in prevalence of hip dysplasia with worsening GMFCS motor levels. Winter Gage and Hicks classified hemiplegic gait patterns into 4 types. Type 4 has involvement of the hip, presenting with hip flexion, adduction, and internal rotation, as well as hip pelvic retraction. Rosenbaum et al., in a population-based study in Canada, evaluated the correlation of motor type or GMFCS and topography. They noted no hemiplegics functioning at the GMFCS 5 level, and GMFCS 1s and 2s combined constituted almost 95% of the hemiplegia cohort. Considering the prevalence of hip dysplasia in the 2 groups, Haglund, in a population-based study in Sweden, noted an overall hip dysplasia prevalence across all GMFCS levels to be 18%. As is expected, 82% of children functioning at the GMFCS 5 level have hip dysplasia. In contrast, the overall prevalence of hip dysplasia in hemiplegics is approximately 1%. Abu Samra and Dr. Miller published a series spanning 24 years, including only 12 patients requiring surgical reconstruction. They concluded that in hemiplegic CP, hip dysplasia is a rare occurrence in adolescents. Now, hip dysplasia in unilateral CP differs from that in bilateral cases. The mean age in hemiplegics is 12 years as compared to 4 years in bilateral CP. While most hip dysplasia in bilateral CP are diagnosed either on hip surveillance or with asymmetric abduction, in hemiplegics, hip dysplasia is frequently detected late, partly because of the low index of suspicion, and usually present with pain or a worsening gait pattern. Radiographs in bilateral CP with hip dysplasia show contralateral hip subluxation in up to 84% of children, while in hemiplegics, the contralateral hip is usually contained at presentation with fairly unremarkable anatomy. Considering the rationale of unilateral versus bilateral surgery, preventive surgery for the contralateral hip is well accepted in bilateral CP. Literature documents a 28 to 44% occurrence of progressive contralateral subluxation requiring reconstructive surgery at long-term follow-up or skeletal maturity. Bilateral surgery is often done on a single day, as stage surgeries are associated with a higher rate of major complications, a longer duration of hospital stay, as well as a higher mean non-surgical operating time. The high occurrence of contralateral subluxation of the hip has brought to light risk factors for the same. A lack of contralateral hip soft tissue release, as well as asymmetric abduction of the hip, are 2 sides of the same coin, which can predispose to an asymmetric positioning of the hip. A reversal of the pelvic obliquity postoperatively, and a high initial contralateral Reamer's index have been shown to be statistically significant factors. An acetabular index of less than 25% has a low risk of subluxation, and while not statistically significant, an age below 8 years has a trend to increased risk. The surgical considerations in hemiplegic CP are different, as the goals of surgery are not the same as in non-ambulatory children. As most children are ambulant, excessive proximal femoral varus is avoided. The older age of presentation brings its own challenges of decreased acetabular remodeling and mobility of the acetabular fragment affecting correction. Thus, the options for acetabular correction are different. Most children are shorter on the affected side, but as they frequently have foot impairments which may affect foot clearance and swing, decisions to correct the shortening have to be taken with careful consideration. The multi-level nature of CP also warrants unilateral multi-level surgery in a single sitting to address associated knee and foot impairments. So coming back to the question, I would suggest that only the affected hip be operated on in hip subluxation in type 4 hemiplegia. The risk factors for contralateral hip subluxation are usually absent, and there are no reports of progressive contralateral hip subluxation in English literature. The hip surveillance guidelines would be best to direct when to operate, and in situations where formal hip surveillance is not possible, a high index of suspicion should direct identification of hip subluxation, which should then be treated if the migration percentage is more than 40%. The treatment of hip subluxation, as would be the case for any hip pathology, would be to prevent deterioration of gait, restore biomechanics to ensure longevity of the hip, and avoid future osteoarthritis. I will go through a few representative cases to highlight some points. This is a 12-year-old boy with left hemiplegia presenting with hip pain of a few months duration and gradually worsening gait. His radiographs show a migration percentage of more than 50% with coxa valga and increased anteversion. He underwent a left varus deviation osteotomy and a Dego osteotomy, which is tricky at this age, but a similar procedure has been recently published by Eric Roots et al. As is seen, excessive varus is avoided, and anteversion has to be corrected, which sometimes requires readjustment of the fixation position, hence the cancellous screw in this picture. The next case is a 10-year-old with right hemiplegia and dystonia functioning at a GMFCS 3 level due to the dystonia. The X-ray shows a short roof acetabulum, which can be addressed by redirection osteotomy after restoration of the shape inside. First adductor release was done, followed by a VDR to obtain a concrete reduction. And since the trident was open, a triple osteotomy was done to improve the ascending approach. 1 year follow-up after implant removal, it is reduced and osteotomy realized. The last case is a 16-year-old boy with dysplasia, however, the trident is reduced. He underwent alone at the ascending osteotomy in the same setting. In this child with capophilia and ascending dysplasia, as the shenton was not disrupted, an anteversion on CT scan as well as intraoperative assessment was not increased, a femoral osteotomy was not done, and a PAO was done for acetabular dysplasia. In conclusion, hip dysplasia and hemiplegia is rare. The considerations for contralateral hip surgery are different from that of bilateral CP. There is no literature evidence of progressive contralateral hip subluxation in hemiplegics, and a unilateral hip surgery would suffice. But the focus of surgical reconstruction is optimizing biomechanics for gait as well as for longevity of the hip. Thank you.
Thank you, Abhay. That was a very comprehensive overview of a rare but important problem, and it's good to get clear guidance from you about how to manage this problem. If we could run the next video, please, Dr. Dhiren, on correction of patella alta.
Correction of patella alta is required many a times in the management of crouch gait. I'm going to focus on 3 important points: why we need to correct, when to correct, and how to correct. The first point is, why do we need to correct? There are 3 reasons for that. The first effect is there is a loss of articular contact of patella and the trochlea. The second is these leads to extension leg or extension leg. And the third is there is a reduction in the lever. Let's understand all the 3 by the pictures. So normally we see that the patellar articular surface is articulating with the trochlea. In presence of patella alta, the patella is not articulating with the trochlea, but it is articulating with the bone of the distal femur, as shown over here. The second effect is on the knee extension. If we want to see the effect, if we ask the child to carry out knee extension in this position, in a normal person with a normal height of the patellar tendon, the person will be able to carry out the full knee extension. However, when the patellar tendon is elongated, the knee will not be extended fully and will remain short of the full extension, which is called extension leg. The third effect is the function of the patella is to provide the lever arm to the quadriceps mechanism, like this, the blue dotted line. In case of patella alta, these lever arm is reduced, And the resultant effect is like this batsman, instead of playing with a normal size of the bat, is playing with a bat which is too short. So he will not be able to bat effectively. The same thing happens with patella alta. The quadriceps cannot function properly. So these are the three effects of patella alta. Coming to the second question, when we should correct it. There are three important questions in this. The first is, what are the indications? What is the earliest age and what is the latest age? The indications are a crouch gait. There is an abnormal Coshino index suggestive of elongated patellar tendon, and there is no flexion deformity at the knee joint, or the deformity is corrected by a surgery like distal femur extension osteotomy. We measure the Coshino index by finding out the midpoint of the distal femoral physis, proximal tibial physis, and the patella. A line joining the patella and the tibial midpoints, known as PT, and divided by the distance from tibia to femur, which is labeled as FT. The Coshino index is the ratio of PT divided by FT. In a normal population, it is around 0.9 to 1.3. Anything more than that suggests that there is a patella alta. The age range, there is no information in the literature. My personal experience is that earliest I have carried out this surgery at 7 years, and the oldest I have done it at the age of 42 years. Coming to the most important point, the surgical techniques. The questions again are, one should go for shortening or advancement of the patellar tendon, whether to use protective suture or not. And the third is which material to use. The shortening the patellar tendon, usually it is carried out like making two holes, one in the tibia, one in the patella. Through that, an encircled suture is passed, and then it's tightened. So that brings the patella to a lower position. You tighten it to the level where you want to bring. That will relax the patellar tendon. Now, this is the situation. Either we can plicate, as shown in this figure, or we can cut it completely and we can suture. This is the second method. There is another method which is patellar tendon advancement, in which the technique is different in immature and mature patient. Let's first of all see the immature patient. Here, again, the same thing, you pass the suture, you relax the patellar tendon. Now, instead of plicating, we detach it from its insertion and we give a new insertion distally and suture it with the periosteum. In mature patient, instead of doing a soft tissue procedure, we detach it with a piece of bone, shift it distally like this, and fix it with a screw. Then there is another method described by Dr. Benjamin Joseph from Kasturba Medical College, Manipal. They use combination of both. They divide the patellar tendon into three pieces. The medial and the lateral piece are separated from the distal pole of patella. The patella is brought down and these slips are sutured to the patella. The central slip is not cut, it's just plicated and sutured to the patella. So this is a combination of both the technique. Which technique is better? Literature does not have any answer to that. Whether to use protective suture or not, again, we don't have an answer. But most of the surgeons, they use it some sort of protective circlage so that whatever repair is carried out is protected. Initially, stainless steel suture was used, but it usually breaks and creates problem. So now we either prefer Ethibond, Vicryl, or fiber wire. Again, we don't have a literature support to tell which one is better, but it's more of a personal preference. So the take-home message is the correction of the patellar tendon length is a commonly used procedure in cerebral palsy. There are many areas where we don't have a clarity, and one should carry out a randomized control trial to find out the answers for those gray areas. Thank you.
Thank you, Dhiren sir, for that talk. It was very crisp and some very important concepts there. So our next talk is by Dr. Jayant. It's on rectus release or transfer. When, why, and how. Can we play the next video, please?
Good morning. This is Dr. Jayant Sampath from Bangalore. I have a special interest in 3D gait analysis and CP management. This talk is on rectus transfer. Stiff knee gait is a common pattern in cerebral palsy. On your right is a typical knee kinematic graph in the sagittal plane, showing how the knee extends in stance and flexes to 60 degrees in swing. Any reduction in the total range of movement of the knee, any reduction in the peak knee flexion value if it is less than 60 degrees, or if there is a delay in the timing of peak knee flexion, all of this could be because of rectus spasticity. Stiff knee causes profound changes in the gait pattern. It frequently causes toe dragging. The foot is not positioned properly at initial contact, and step length is reduced. In addition to co-spasticity of rectus and hamstring, low power generation by the ankle or at the hip and reduced walking velocity can also cause stiff knee gait, and these causes have to be ruled out by 3D gait analysis prior to surgery. Rectus can be released proximally or distally. Distally, resection is now favored, or it can be transferred to the medial or lateral hamstrings or to the ITB. Proximal rectus release had really no effect on knee kinematics, and this operation is not used for stiff knee gait. Distal resection was first described 10 years ago by Dr. Presedo and colleagues, and it's gaining popularity over time because the transfers tend to scar down over time. And we know from biomechanical studies that the rectus femoris does not act as a knee flexor. So a distal rectus resection may be a simple and good option, but long-term studies are still awaited. So at present, the rectus transfer is the gold standard procedure, most widely performed with the longest follow-up on the largest numbers of patients. But we know that it does not work in every case. This long-term study showed that 1 in 5 patients had permanent failure and 1 in 6 had some form of recurrence. The main reason why rectus transfer doesn't work in some patients is because of a high preoperative knee flexion angle, and this has been confirmed in multiple studies. An example of a child who was walking in persistent flexion of 60 degrees throughout the gait cycle, this child will likely not benefit from a rectus transfer. Another study, a randomized trial, suggesting that if there is any doubt, to avoid rectus surgery and to defer it to a later time, perhaps at the time of hardware removal. And using this approach, an unnecessary rectus transfer can be avoided in up to 50% of patients. So this boy represents a subgroup that will probably benefit from rectus transfer, good extension in stance, but lack of full knee flexion and swing. So again, GMFCS level 2 child will probably benefit from surgery. So GMFCS level again had a big influence on the outcome, with patients in levels 1 and 2 doing much better than 3 and 4. And rectus transfer may actually worsen crouch gait if done in supported ambulators. So whether to combine it with hamstring surgery or not, this study published in 2017 shows that it can be combined with hamstring surgery, but it's better to do it after 3D gait analysis pre-op. To summarize, rectus femoris transfer is a common procedure in CP. Results have been variable in the literature, mainly due to poor patient selection. The ideal candidates are GMFCS levels 1 and 2, where their knees are stuck in extension. The higher GMFCS levels 3 and 4 with high preoperative knee flexion will likely worsen after rectus surgery and should be avoided in these cases. Rectus transfer is at present the most reliable option at present, though rectus resection is gaining in popularity. Thank you.
Thank you, Jansa, for that talk. It's very important to realize the need to individualize rectus surgery. I think we have a lot of questions in the chat box. A lot of them have been answered. Maybe we can discuss a few of those so that the audience can also participate in that. So I think we can start off with Dr. Mollin's question about the role of arthroeresis. I think the case that Dr. Taral put up was an eye-opener. Any thoughts from Dr. Abhay and Dr. Kishore about arthroeresis in planovalgus feet?
Thanks. Yeah, if I could, I put a comment there in the chat message as well to say a lot of the problems in the planovalgus feet relate to weakness. So the contrast between equinovarus and planovalgus is that equinovarus is a muscular problem and planovalgus is a joint instability problem compounded by weakness. The contracture is a secondary effect of the hind foot being pulled into valgus. So the correction of the gastroc with a strayer is only part of the correction. The weakness in the tibialis posterior in a planovalgus foot is a much bigger problem, and we don't really have a solution to that. So when I kind of see where Taral is going with it. Say he's got a young patient, he wants to preserve mobility. In polio, people will remember we used to do a non-fusion technique for correcting hindfoot valgus. So the arthroeresis is just a modern variation on that. The treatment effect will be small. You need to control it with an AFO still, and you need to maintain a strengthening program. And then in those children, it might work. If weakness is a bigger issue, the deformity is moderate to severe, then the treatment effect of an arthroeresis is not enough.
Any thoughts,
Yeah,
Dr. Kishore?
Yeah, I'd say, I agree with what Abhay said. I have no experience using arthroeresis for CP, and I don't think it'll work. I mean, if you are trying to do something to fix a planovalgus deformity in CP, that means bad enough that it needs a proper treatment to fix it. So arthroeresis is mainly popularized, actually, dare I say, by podiatry in the Western world to treat a lot of asymptomatic flat feet we may not even treat. So I'm not sure that I would use that as a treatment option in children with cerebral palsy.
Sandeep had a question.
Sorry, if I could just say, I've done it twice in all these years, and both were in kids who needed it, but who were severely autistic and would not comply with post-op rehabilitation after an os calcis lengthening. So it was possible to use something different, but they were able to get up and walk on it straight away. So that's the only time I've used it and it's worked, but otherwise everything else remains.
So I've used it in 5. So 5 is better than 2. But it just goes on to say that the limitations are very, very, So limitations are very restricted. This was just to illustrate that in a high functioning CP where valgus foot is a problem, this is one of the options. And it doesn't work moment you get onto the real deformity.
Abhay, I just wanted to ask whether a Grice green works better than the screw, because I have done a lot of Grice green and they give really good lasting results.
Yeah, like I said, that's the one you and I did together, if you remember. So yes. It's a perfectly valid procedure in that sense. And if you understand the biomechanics, you'll realize that the Grice green is actually able to maintain the position of the foot. Remember, it's a stance phase problem. Yes. And protecting the ground reaction force in the stance phase is probably goal number 1 for all CP surgery. And I think that will achieve it much more effectively.
So there's one important point that was brought up by Dr. Kishore about the asymmetric diplegics. And I think we need to kind of talk about that a little bit. So the asymmetric diplegia also kind of puts in another factor to consider when we're talking about other surgeries, foot surgeries and things like that. So Dr. Kishore, how much would you investigate to be sure that you're dealing with an asymmetric diplegia rather than a hemiplegia?
Yeah, so I think this is where purists like Abhay and I remember working with Kier, and he would say no diplegia is symmetric as much as we think. But I think the more important to keep in mind, they're so asymmetric that one side looks almost like what you see with type 4 hemi. So that leg is really internally rotated compared to the other side, and they're walking almost like hemiplegia on one side, but they actually have diplegia. So that's a really important one to keep in mind. And if you follow the traditional hip surveillance guidelines, you actually discharge them by age 10 because they're GMFCS2, their x-rays look normal, and you discharge them. But we've had 5 of them now that have come back with severe hip disease, and one actually had hip dislocated. And the family is like, look, we were told not to come back, and you said the hips looked fine at age 10. So it's important to keep in mind that those where they are diplegia, but one side is so far off. So we're actually now between our team and the group in Queensland. So we're actually doing an entire analysis of our gait lab database to look at what is asymmetric die, and if so, how many degrees of internal rotation and what parameters, and really going back and looking at their hip x-rays now when they come back to order new x-rays to really look at if we can give some guidance. But including our own BC hip surveillance guidelines, we don't talk about that as yet as a consideration to keep in mind, and not discharge the GMFCS2s and 3s if they're so asymmetric. And if so, what is asymmetric is still yet to be determined.
A couple of questions from the Q&A. For equine varus deformity.
I just wanted to ask one question. So for same GMFCS level.
Sorry, I missed that.
Go. Okay. Taral, you want to go?
Okay. So for same GMFCS level, a symmetric die is more likely to have a hip problem than a symmetric die. Am I correct when I say that?
Exactly right. Yeah, that's exactly, Taral. So if you see a child who is on one side is almost walking like what we see with the type 4 hemi, and a lot of them develop actually over a period of time, or you've done derotation osteotomies to correct their, say their internal progression angle, and post-operatively one side they continue to turn in and walk. Those kids, you really need to watch them closely and also watch their hips. And we found now 5 of them were really bad. There's many others we're actually finding now. 5 were so bad that we missed those hips, and they're still in a lot of trouble. And one of them actually ended up getting a hip replacement.
So Abhay has a comment, and then we'll wrap up.
Sorry, just to add to that, I agree this is a complicated problem, but just to try and help simplify it, what I would suggest is that if you start with the GMFCS level and then look at the phenotype, these 2 starting categorizations will allow you to decide whether the problem that you want to approach is a gait-related issue or whether it is a hip development-related issue. And then you can decide what your approach is going to be. To look at asymmetric diplegia for gait is very different to looking at asymmetric diplegia for hip development. They're 2 different issues. So for the sake of clarity, I think stratifying it that way will make it easier for people to understand what it is that we are approaching and why we are approaching it that way.
Lovely. Thank you so much. It's been a really wonderful learning experience on a Sunday morning. We have 130 pediatric orthopedic surgeons from all over India logging in to listen to us. So thank you so much to Kishore, to Abhay, and to all the faculty from POSI. And I hand over the virtual dais back to the organizers. And thank you, Abhay.
I should thank Dr. Jayant for his input. He's worked behind the scenes with the with all the topics. So a thank you to Dr. Jain from all the faculty. Thank you.
Yeah, thank you, Jai. Thank you, Abhay Gahukamble. Now we move on to the next session, and the next session is on the free paper. I invite Dr. Sanjay Balke and Dr. Damodar to be the chairman for this session. We have 7 papers in this session. The presentation time is 5 minutes. At the end of 5 minutes, the presentation will be stopped, and we will have 2 minutes for the questions and answers. So over to you, Dr. Sanjay and Dr. Damodar.
Am I audible?
Yes.
Yeah. Good morning to all. We welcome you to the penultimate session of this conference. The first talk is by Dr. Abhishek Bhasme on Indian-made telescopic rods in managing osteogenesis imperfecta. So over to Dr. Abhishek Bhasme, please.
Good morning, I am Dr. Abhishek S. Bhasme, and I'll be presenting my paper on Indian-made telescopic nails in managing osteogenesis imperfecta. My gratitude to Dr. Vidya Prasad and POSI for this opportunity and encouragement. We all know osteogenesis imperfecta is a rare heterogeneous group of disorders characterized.
Sir, the echo is from the video itself. I'm sorry about that.
By brittle bone, resulting in frequent fractures and skeletal deformities. Deformities of these long bones are common and often require surgical correction. Telescopic nails such as FD nails have become standard treatment for such deformities. Most of these telescopic nails are manufactured by foreign companies, hence are very expensive for the Indian population. Indian replicas of the telescopic nails are available and is widely being used for management of such conditions. We have the first and the second generation of these implants, and presently the third generation as well. The objective of the study was to determine the efficacy of these Indian rods and to identify complications associated with them. This is a retrospective analysis conducted at Indira Gandhi Institute of Child Health, where children with OI and who have undergone telescopic nailing for lower limb deformities and with a minimum 2 years follow-up included. Telescopic nailing was done using the Indian telescope nails and the standard described approach and technique. Postoperatively, they were protected in a cast or a slab for 6 weeks, followed by bracing. All children were on bisphosphonate therapy. They were followed up at regular interval, and at each visit, clinical radiographic examination was conducted to assess for any recurrence of deformity, refracture, failure of implant, or any associated complications. The surgery of each child was done as per standard protocol and approach to these telescopic nailing. Coming to the results, we had 32 patients with 82 extremities, which were included in the study. The mean age of the study population was 8. All fractures following osteotomies had united by a mean of 8 weeks, and the mean follow-up was 3 years, 9 months. We had anterior cortex breach of the male rod was observed in 7.6% of the cases, as shown in the intraoperative picture as well as the X-ray. There was proximal migration of the female rod in 6.5% of the cases, and failure to telescope was observed in 52.2% of the cases. Bending of the nail at the male-female junction was seen in 10.8% of the cases, and 6.5% eventually had refracture. Revision was required in 46% of our cases. The Indian nails cost approximately 5% of the other counterpart, such as FD nails and foreign-made nails. Coming to discussion, we see that the complication rates are more or less the same even with the Bailey-Dubois rods or FT nails, whereas this paper shows a complication rate of about 52% in tibia and 21 in femur, whereas another paper showed a reoperation rate of almost up to 50% when they used Sheffield telescopic intramedullary nail, and in FT nails, the revision rate was 53%. So in conclusion, Indian telescopic nails are affordable. It gives good short-term results, but on a long-term, results vary and there is a need to improve the design and the quality of the nail for better functionality. Thank you.
Any questions on this?
Can I ask a question?
Yes, please.
So, Dr. Abhishek, I think that there are two parts to the story. I do agree that the Indian nails are not as perfectly designed as the imported ones, but I think there is a larger problem of the learning curve of how to do the surgery. Because a lot of times the nails are not placed concentrically and in the center of the physis, proximally and distally, or they are placed with inadequate overlap, which is why the nail bends at the lower margin. And the biology also has something to do with it. So I think it would be unfair to put all these as bad quality implant. This is a very demanding surgery. It has a very high learning curve for performance, and the disease itself is not a very conducive disease because there are so much variations in the type of OI that you are treating. Those are my question and comments.
Thank you, sir. I agree with you, sir.
One comment I want to make, Sandeep, here is that the real problem here is the mismatch between male and female rod. The male rods are very thin as compared to the female rod because of the machining problems. And I'm sure people can do something to improve the machining.
Yeah. So I agree that it is not that the nails are totally perfect, but the unusually high complication rate cannot be all attributed to the nail. It has also a large amount to do with the disease and the training.
Right. Can I make a comment?
Maulin, sorry, we are running late, and yeah, please invite the next speaker.
Next talk is on relapsed club foot, our approach and outcome by Mohammad Yaqub. I invite him for the next.
Good morning, everyone. I'm Dr. Mohammad Yaqub, doing fellowship in pediatric orthopedics in Indira Gandhi Institute of Child Health, Bangalore. And my topic of presentation for the day is relapsed clubfoot, our approaches and outcomes. Introduction. Ponseti method revolutionized the treatment of clubfoot. However, relapse of the deformity continues to be a major problem, occurring in up to 40% of the patients. And managing this relapsed clubfoot can pose a challenge as there are various approaches and no consensus on the same. The most common factors causing relapse are non-compliance for the treatment. The other causes could be neurogenic clubfoot, syndromic clubfoot, tarsal coalitions, etc. Materials and methods. This is a retrospective and prospective study involving all the patients diagnosed with a relapsed idiopathic clubfoot and who are managed at our institute between 2015 and 2020. Retrospective chart reviews was done to identify the residual deformities, causes of the deformity, and the intervention done. The relapsed clubfoot was classified using Bhaskar A classification of relapse pattern. The follow-up protocol followed in our hospital was a weekly assessment of the child, their ability to squat, the deformities present in the foot, and analyze the gait and the brace used by them or not. This chart shows the classification of relapse pattern in clubfoot following Ponseti treatment given by Bhaskar. He divided the deformities into 3 groups, and in sagittal plane as well as the coronal plane. That includes the ankle equinus, forefoot adduction, and dynamic supination. Usually, the age group of presentation was around 1.5 to 3 years of age. Prospectively, the children were followed up to assess for the outcomes using assessing clubfoot treatment score, which assess for plantigrade foot, pain, ability to wear the desired footwear, and the parent satisfaction. Also, they were assessed for any further relapse or residual deformities. This chart shows the ACT questions and score, which had 4 questions, and that was scored from 0 to a maximum score of 3. And the total score of maximum was 12, which indicated the child had a good outcome. The results of the 1,435 clubfoot treated at our clubfoot clinic, we observed a relapse rate of around 20.5%, that is around of 294 kids, of which 27.9% had dynamic supination with forefoot adduction, which is classified as grade 1B according to Bhaskar classification. 22.1% had fixed ankle equinus, that is grade 2A. 11.5% had fixed adduction deformity of forefoot, that is grade 2B. And 38.4% had 2 or more fixed deformities, that is grade 3. Relapse were associated with inadequate bracing in 52% of children. Children with grade 3 relapse underwent repeat Ponseti technique, of whom 64 kids responded well, 32.7% required a PMSTR, and 10.6% underwent Ilizero correction. Ilizero correction was done in kids of a higher age range, that is of around 3 to 5 years, and PMSTR at a slightly younger age of around 1.5 to 2 years. All children with group 1B underwent tibialis anterior tendon transfer, and of them, 1/3 required a simultaneous TA tenotomy. Group 2A relapse of 66.1% required a repeat percutaneous TA tenotomy, and 21 children required TA lengthening with posterior capsular release. Among the grade 2B, 14 patients underwent lateral column shortening and 3 needed metatarsal osteotomies. This is a clinical image of child aged 4 years showing forefoot adduction, slight cavus, and equinus, which was corrected by Ilizero technique. This is another child of age 2 years showing forefoot adduction and dynamic supination, which was treated by tibialis anterior tendon transfer. And the last image shows a clinically corrected foot. The mean follow-up duration was 1.4 years. On assessing the ACT score on follow-up, 70.9% had good outcome, and 5.5% children complained of occasional pain, but not limiting their activities. 8% had residual deformities, and 4.4% had again presented with relapse of the deformity. Conclusion: relapse in the clubfoot can present in various combinations, with the most common being grade 3, that is 2 or more fixed deformities, followed by forefoot deformity. Ponseti method can help manage a majority of them, but each type of relapse pattern requires different approach. Early identification.
Yes, paper is open for the discussion. Any question? Okay, if there are no
I have one
questions.
question.
Yeah, please, Dr. Gupta ji.
What was your indication for use of Ilizero? Actually, which patients? You said you did Ilizero in older patients.
Yes, sir.
So
Sir,
was it like a problem with the equinus primarily, or was it something else?
Sir, actually, the child who came back with the relapse, we tried the normal Ponseti casting techniques for at least 5 to 6 casts, and following which the foot was not abutting at all. And as the age of the child was more and there was a more of forefoot adduction and equinus together, then we thought of correcting it with the Ilizero.
Can I ask a question, sir?
Did this feet had stiffness post-surgery, post-Ilizero, or were they having a supple foot?
So the ankle showed a minimal, the foot was corrected to neutral and a slight stiffness was there, sir. Then we had advised a physiotherapy and probably it would have been recovered, sir. We lost the follow-up of the child.
Okay, yes, Maulin, your question, please.
So you have shown that 58% of relapses were non-compliant with bracing. That means 42% patients with relapse were wearing brace. How did you confirm brace compliance in these patients? Or how did you inquire whether children were compliant with brace or not?
Sir, we usually ask the parents till what age did they use, sir. Usually when the child started walking, the parents thought that the deformity was almost corrected and they stopped using. And few other parents told us that at the night when they put up the brace and by the morning the child woke up, it had slipped off. The brace had slipped off.
We relied on parents. Yeah, thank you.
Yes, sir.
Okay, Chairman sir, please invite the next speaker.
The next speaker is Dr. Anil Agarwal. He will speak on the effect of non-vascularized fibular harvest on donor limbs, a prospective radiological analysis in 25 donor limbs. Dr. Agarwal, please.
The effect of non-vascularized fibular harvest on donor limbs. I am Dr. Anil Agarwal from the Department of Pediatric Orthopedics, Chacha Nehru Bal Chikitsalayah, Delhi. Dear friends, fibula is an important autologous graft site in children and is put to use in many pathologies where filling of defects or osteogenesis is required. We have been using this graft for several years. We utilize a periosteal preserving technique and only diaphyseal portion is used. Let's take up an example. Non-vascularized fibula harvested followed by an uneventful regeneration within 6 months. In another case, same technique was used, but the fibula remained non-regenerated and ankle valgus developed in this case. What went wrong? The observation posed many questions which we tried to answer in the current study. The study was undertaken in 25 fibular donor sites. Methodology involves serial radiographs obtained preoperatively, postoperatively, and at 6 months. Intraoperative clinical photographs to assess the periosteal breach and measurement of the harvested fibular length were also done. At follow-up, longitudinal regeneration of the fibula, lateral distal tibial angle, that is LDTA, and distal fibular station using Malhotra glades were quantified. So in results, the findings were that in our cases, average 65% of fibular length was used and distal remnant approximated about 20% of total fibular length. 72 fibula were harvested with intact periosteum. Fibula was regenerated in 60% of the limbs at 6 months. The complication of ankle valgus was present in 23% cases at follow-up. Now let's go back to our question number 1 regarding relationship of periosteal preservation to fibular regeneration. 4 different scenarios were observed, 2 probably expected and 2 unexpected. First one was regeneration with intact periosteum, and this happened in 12 out of 18 limbs. Next, non-regeneration with periosteal breach. However, there were cases where non-regeneration was present despite an intact periosteum. Contrarily, regeneration with a periosteal breach was also noticed. Statistical analysis gave some quantitative values. There was 2.6 times increased likelihood of non-regeneration if periosteum was breached. There was one indirect observation also. Not all periosteal breach would result in non-regeneration. Now for the second question, does proportion of harvested segment influence regeneration? Well, it did not seem so when analyzed statistically. For the third and final question of distal fibular remnant relation to the ankle valgus, again, the answer was negative. However, in none of our cases, the distal remnant was less than 15% and still the ankle valgus could not be averted in many cases. There were additional interesting observations from the study. There was a very strong relationship of developing ankle valgus if the fibula remained non-regenerated. Are there any clinical learnings from the study? Definitely yes. There will be approximately 1/3 limbs where despite periosteal preservation, non-regeneration would occur, indicating factors other than just periosteum being involved in regeneration. Additionally, the observation of ankle valgus despite adequate distal remnant made us revisit the ankle mechanics. Fibular harvest acutely dismantles the ankle stability provided by the long fibular stud articulating with fibula at two joints. And this factor prompts ankle valgus rather than the length of the distal remnant. When fibula stabilizes early, the process is halted and ankle valgus does not develop. No wonder this phenomena was reflected as an abducting distal remnant in almost all cases where fibula regenerated. To conclude, for the factors under the surgeon's control, periosteum preservation increases the chances of regeneration. You can enhance stabilization or enhance early healing, and this may prevent ankle valgus. Lately, we have supplemented fibular graft site with artificial graft.
Yes, paper is open for the discussion.
Yes, Dr. Anil Agarwal, can you complete your conclusion? We wanted to learn about it, please.
Sir, basically, it's the when you remove a fibula, the articulation between tibia, the fibula is a long bone, and there is a strong articulation between tibia and fibula. So when you harvest it, there is acute instability. So as a surgeon, what you can do is that you can help either fix it, which we do when we detect ankle valgus, we transfix the tibia fibula. So you can either do that, but that disturbs the ankle mechanics, because when you pin the fibula to the tibia, you have either you place a block, otherwise the fibula will abduct. Next method is that you use a artificial bone graft, which helps regeneration as early as 3 weeks. Now lately we have using this, and as shown in this example, within 3 weeks the fibula regenerates, and in these cases the ankle doesn't move into valgus. You have to restore the longitudinal relationship as soon as possible.
Okay, fine. So basically we move on to the next talk. So Chairman sir, please invite the next speaker.
The next speaker is Dr. Venkatesan Sampath Kumar, talking on analysis of transverse plane kinematics in patients with spastic diplegic cerebral palsy. Is it a deformity or a compensation?
Good morning, respected seniors and dear friends. I am Dr. Venkatesan Sampath Kumar from AIIMS, New Delhi, and today I'll be presenting our research on analysis of transverse plane kinematics in patients with spastic diplegic CP. This is my brief CP, and presently I'm working as associate professor. I do not have any disclosures pertaining to the study. We all know about cerebral palsy, which is an insult to the developing brain, leading to loss of inhibitory signals to the spinal cord. Although the insult is static, the deformities can be dynamic. We also know that the dynamic and static clinical measurements may not always correlate every time, and there are various ways to assess the dynamic abnormalities, including the Edinburgh Visual Score and multiple applications available. Although there are numerous ways available, the instrumental gait analysis is still the gold standard, despite its cons of high initial cost and steep learning curve. Today, our primary aim was to understand the transverse plane kinematics in diplegic CP patients. We did a retrospective study in our tertiary referral center on spastic diplegic CP patients. All patients underwent a careful physical examination before analysis. We used the BTS Italy gauge system with 8 force plates and 12 IR cameras, and we used the Helenius protocol. This is how our typical gait analysis report would look like, with all the temporal spatial parameters and the kinematic analysis and the EMG analysis. Today, we will be concentrating on the kinematic analysis, especially the transverse plane. So every patient is classified based upon the predominant gait pattern. Then within the transverse plane, the deformity is described. For example, in this graph, the green color depicts the right side, which shows a 30-degree of external rotation deformity, of which 50-degree of internal rotation from the hip is compensating. However, on the left side, there is a 15-degree hip internal rotation and 10-degree tibial internal rotation, leading to additive deformity. And whenever we have deformities at more than one side, we classify them as either additive or compensatory. Out of a total of 20 40 patients with 40 limbs. We had 12 females and 8 males. The mean age was 11.7 years. The most predominant GMFCS level was level 2, followed by level 3, and the most common gait pattern was crouch gait. So this is a case example of a 12-year-old female with a spastic diplegic CP with a crouch gait pattern GMFCS level 3. And this is the gait pattern in the sagittal view. And we can see that the child had a bilateral crouch gait pattern. The right tibia is externally rotating by 50 degrees, whereas in the left tibia, there is an internal rotation of 20 degrees. The right hip is trying to compensate for the external rotation by internal rotating. So this is a compensated deformity. There's a midfoot breach, which is not picked up by the protocol, which is a disadvantage of this protocol. Another case example, 14-year-old male, the spastic diplegic CP. This child had undergone a well-paced procedure 5 years ago with history of frequent falls at the moment with bilateral indwelling gait. Now we can see that on the right side, the hip is having an internal rotation, which is probably due to the increased femoral activation, whereas on the left side, the hip is neutral. So the right side internal rotation is coming from the femur, on the left side, it is coming from the tibia. So this is a case example of a 9-year-old male with a spastic diplegic CP with more jump gait pattern on the right side. With a, and on the right side, you can see there is a 10 degree of internal rotation, probably due to severe weakness. So the right hip is showing a hemipelvic retraction, which is probably a compensation for internal foot progression angle and the increased limb length. And the left hip is externally rotated, which is again a compensation for the hemipelvic retraction to get the left limb along the line of gait. So this is our master chart where each and every patient has been classified as with the predominant gait pattern, and then the primary deformity or the compensation has been defined, and then we have defined it as whether there is any additive deformity or there is any compensation. And this is for the 20 patients we have included. So the summary of our results show that the deformity is additive in 7 patients, where however compensations in the transverse plane can be seen in 16 patients. In 2 patients, that is both additive as well as compensatory mechanisms. Of all the compensations, majority of the compensation is happening for the femur, and this is happening for deformities of the foot as well as the tibia. So hence, it is very important to get an instrumented gait analysis to understand these different abnormalities accurately, so that we do not either overdo.
Yeah, paper is open for the questions.
So, Dhiren, it's a good paper.
Sorry, the presentation was not over. Actually,
It's already 5 minutes are over, so that's why I have cut.
Oh, okay,
Yeah.
right.
Mahek, I'm cutting the presentations when 5 minutes are over.
Okay, right. No issues, sir.
Yeah, Taral, please.
Yeah. So one of the problems with measurement of rotational issues in gait analysis is that when anatomically we measure a rotation, for example, with a CT scan or clinical measurement, it is the rotation between the proximal and distal femur or proximal tibia and distal tibia. When we do gait analysis, the measurement is between pelvic markers and femur markers and tibial markers. So it assumes that there is a rotation taking place at a joint where actually none is taking place. So there is a fallacy in those measurements, and the world is still trying to correct those. So the experience with your study as per the interpretation of rotations is concerned.
Thank you, sir.
Any comments on that? How did you then interpret?
Sir, I appreciate that this is a problem, but as I told you, when you do the CT scan measurement,
Okay, fine.
Or the compensation from the pelvis.
Okay, fine. Let's move on to the next talk.
Friends, we have gone through a hard time over last couple of years due to COVID. Now we have an interesting talk by Dr. Chintan Doshi on impact of
But
COVID
with the gait
pandemic
analysis, we
on
are
the
also
children with
estimating the
cerebral palsy.
Hello everyone, I'm Dr. Chintan Doshi from Mumbai. I'm here to present my paper on impact of COVID on children with cerebral palsy, a survey that we conducted at our Xavier's Gate Lab in Mumbai. I would like to thank my co-authors for this study. Children with cerebral palsy have their activities which depend mainly on routine physical therapy, social interaction, and frequent visits to doctors for any specialty consult, for orthopedics or for neurological consult. COVID has affected all of us and is affecting still. We are in the beginning of the third wave, and what a time to present this study, which we conducted based on the first two waves. At the end of the second wave, when we conducted this questionnaire, the COVID-19 has affected cerebral palsy kids even in the form of their hindrance in their social interaction, therapy, medical management, and surgical management. So presenting this paper where COVID pandemic has been raging for last 2 years and has been affecting us, it has affected these kids in terms of their formal schooling, access to rehabilitation, and limited physical and social activities. The aim of this study was to assess availability of healthcare services to cerebral palsy kids during pandemic in terms of daily routine physical therapy, rehabilitation, follow-up visits with specialty doctors, requirement of orthosis or splints, hip surveillance, and any other behavioral changes that could have occurred in children with cerebral palsy due to pandemic. We conducted an online survey which consisted of 9-part questionnaire consisting of 26 questions. This included demographic data, physiotherapy questionnaire, orthotics and splint adjustment requirement, specialist consultation, then deterioration of function, recurrence of deformity, need for surgical intervention, changes in behavior, or infection of COVID-19 infection within the family. So we had 101 respondents in the form of parents and caregivers of the cerebral palsy. The age group of these kids were from 2 to 18 years. There were 66 males and 35 females. Most of these were from level 2 GMFCS, ambulatory cerebral palsies, most likely. And most likely they were spastic diplegia. Spastic hemiplegia also had a significant proportion of occurrence in this study. So from the questionnaire, we had deduced some results in terms of assessment of assessed to therapy compliance during pandemic. Out of the 101 children, only 39 children could undergo continuous therapy like how they were undergoing physiotherapy before before the pandemic had started. 36 had shifted to intermittent therapy, wherein the sessions were reduced and the therapy was affected. 26 of 101 children had no access to physical therapy or of any form. Out of the 39 continuous therapy cases, we had 13 of them visit by a therapist. 1 of them had shifted to online therapy. 8 of them had combination of these sessions. In terms of requirement for orthosis and online consultation, 51 parents or caregivers expressed the need to make a new AFOs or splints as the old ones had worn out or changes had to be made because of the deformity or recurrence or increase in spasticity. Specialty consultation was shifted to online consult for orthopedics, neurologists, and other specialists in 51 of these cases out of the 101 cases. We evaluated loss of function and surgical intervention. So almost 57% of them had deterioration in ambulatory status. 64 patients had increase in muscle stiffness and tightness. 34% had worsening of upper limb function. Of the 49 patients who were advised surgery prior to pandemic, out of the 101 kids, 29 could undergo surgery between the 2 pandemics. The rest 20 patients had missed out on the surgery at least until the end of the second wave.
Yes, the paper is open for the discussion. Any question? Fine, sir. Then you can invite the next speaker. Dr. Puneet is not presenting, so we need to invite the next person.
Yes, I invite Dr. Jaideep Damele for rehabilitation, function, and return to school and sports after growth modulation surgery using 8 plates.
Good morning, respected chairperson, my dear colleague. Myself, Dr. Jaideep Damele. I am presenting my paper on results of earliest return of function in angular deformity correction after growth modulation using 8-plate and PET screw. Introduction. Correction using hemiepiphysiodesis with 8-plate and PET screw is a popular, minimal invasive, early return to function method for correction of uniplanar deformity in children. Delay return to function has been previously reported after growth modulation surgery by Fillingham in 2014. However, the exact time for the return to school and sport has not been studied. Aim of study. The current study examines the return to mobility, day-to-day activity, return to sports and school in children who underwent growth modulation surgery. Material and method. A retrospective study. 50 patients underwent growth modulation surgery, 22 male, 28 female. Out of 50 patients, 19 underwent 8-plate, 31 underwent PET screw. Segment 2 tibia, 12 femur and tibia, 36 femur. We have recorded the following activity: stair climbing, squatting, sitting cross leg, going to school, fast walking, running, returning to sports. We have recorded pain scale on the basis of visual analog scale. Here, 0 is no pain, 10 is maximum pain. Results: at 4 weeks, 3 out of 19 patients who underwent 8-plate had pain. 2 out of 31 who underwent PET screw has pain. Active range of movement achieved by 4 weeks in 8-plate group was 102.6 degree. In PET screw, it was 126.4 degree. Passive range of movement achieved by 4 weeks in 8-plate group was 120 degree. In PET group, it was 130 degree. Active and passive full range of movement achieved at 12 week in 8-plate group and 9 week in PET group. Extension lag at 2 week in 8-plate group 16.6 degree. In PET group, it was 8 degree. Extension lag disappear by 6 week in 8-plate group, 4 week in PET group. Ambulation. Day 3, only 2 out of 19 patients able to walk independently in 8-plate group, 13 out of 31 patients in PET screw group. By 2 weeks, 17 of 19 patients able to walk independently in 8-plate and 30 out of 31 patients in PET screw group. We recorded stair climbing, sitting leg cross was achieved early in PET screw group, then 8-plate. Squatting only was achieved early in 8-plate group, then PET screw. Only sitting leg cross shows significant p-value. We have recorded activity stair climbing 4 week in 8-plate group, only 86.4% patient. In PET screw, it was 87%. At 12 week, 8-plate shows 94.7% patient, and PET screw, it was 90.3%. Squatting, which was early in 8-plate compared to PET screw group, at 4 week, 57%. At 12 week, it is 94.7%. Sitting cross leg at 4 week in 8-plate, only 36.8%, and PET screw, it was 58%. At 12 week in 8-plate, it was 94.7%, and PET screw, it was 93.5%. Going to school, rapid walking, running, return to sports was achieved early in PET group, then 8-plate. Activity at 4 and 12 week. Going to school in 8-plate group at 4 week, only 84.2% patient, while in PET group, it was 93.5%. At 12 week, 8-plate group, it was 89.4%. In PET, it was 100%. All the patients that attended school at 12 week. Rapid walking at 4 week in 8-plate, 31.5. At 12 week, it is 94.7. Running At 4 week, 15.7 in 8 plate and 32 point in PET screw. At 12 week, in 8 plate is on 94.7 and PET it was 96.7. Return to sports at 4 week in 8 plate only 10.5% patient. At 12 week it was 84.2, while in PET it was 87%. Conclusion: ambulation mobilization start early in PET screw group than 8 plate. Return to sports activity early in PET screw group than 8 plate. Going to school, rapid walking, running was early in PET screw group than 8 plate. Squatting was achieved early in 8 plate comparatively PET screw. The rate of correction was faster in PET screw group than 8 plate. Limitation: retrospective study with limited sample size. The study has.
Yes, paper is open for the questions.
Yes, I have one question to Dr. Jaideep. The patient follows up you with late. Say valgus deformity, you have either done 8 plate or PET screw. He follows up late and now he has gone in Mars. Now what method, PET screw or 8 plate, you think was better in this case? Or you need to do a resurgery with another 8 plate on the opposite side?
So here we have to see the alignment view depending upon the previous deformities valgus and then it's shifted to varus. We want at least 1.5 years skeletal growth remaining. We want lateral elbow x-ray to know the exact skeletal age. Depending upon how much growth is reversed, we want to do the opposite side growth modulation either with 8 plate or PET screw depending upon your child. If the patient is near skeletal maturity, we prefer PET screw for faster correction.
Yeah, Rajiv, your
Yeah.
question.
Yeah, nice paper, Jaideep. Just wanted to know what was the reason that these kids start bending the knees late. Just as a comment also that when the child is still under anesthesia, we just show parents that he is able to make the full knee range of motion. And that gives confidence to the parents and they are sort of motivated.
Yeah, that's why we are presenting this paper. So as previously literature suggests that though some are the risk factor, those who are underwent the femoral plate, those who are the older kids, they are the high risk for the return to mobility late. That's why we have to counsel the patient and start as early as possible physiotherapy. Compare it with PET screw, you can see the result. PET screw will give everything early except the squatting, attending school, going sports activity, all early in PET group. Irritation of the screw
please,
on
your
medial
question.
side.
Yeah, Jaideep, we have heard that. Yeah, so Sandeep.
Between the rehabilitation in males versus female.
Sandeep,
Yeah.
we can't hear you. Can you please?
Hello.
Yes, sir.
Did you find a difference in the rehabilitation in males versus females?
Yeah, we had done the gender basis also.
Sensitive to the surgery around the knee. So does the sex make a difference?
Yeah, so if we in our study also female child compared to may show return all the function.
They show earlier return.
Late female.
Late.
Yes. Female, some are the high risk factor. Female, age older than 10 year, bilateral surgery and femoral plate.
Okay.
Okay, so there was a question from Dr. Prakash Chavan about the age. Already you answered that question.
Yes.
Yeah, thank you. Right, so let's move on to the last paper of the session by Dr. Taral. Yeah, sir, please invite Dr. Taral.
I invite Dr. Taral Nagda for the last paper of this session.
My name is Dr. Taral Nagda. The topic of my paper is simulated weight-bearing 3D CT scan makes a difference in the planning of computer-assisted correction of genovalgum using patient-specific 3D printed guide. I want to thank my co-presenters, Dr. Jaideep Damele from Jupiter Hospital, Mr. Sagar Parekh and Ms. Rashi Gupta from Imaginarium for helping me with this paper. So computer assisted deformity planning and correction using a patient specific 3D printed guide is state of the art for correcting deformities in children and adults today. This is the process of doing such a deformity correction, and it starts from acquiring a 3D data from a CT scan. Now we know that for any deformity correction in lower limb, a full length standing AP radiograph is essential. CT scan, however, is a supine phenomenon. To get a standing CT scan in erect position for lower limb deformity data collection is not possible. So there have been studies which show that 3D data from a supine CT scan are different from data obtained from a standing scanogram which is done in erect position. There are new CT scans which are available which can acquire data in a standing position. However, these CT scans are expensive, experimental and unavailable at present in our country. So we developed this technique to simulate a weight-bearing CT scan in a lab, and this was done by superimposing the 3D data from a supine CT scan onto a weight-bearing X-ray scanogram. And there was a special software which was used to do this simulation. So we could get a simulated weight-bearing CT scan. The research question which we put forward is that is there a difference in lower limb alignment between the data as far as standard supine CT scan is concerned and simulated weight-bearing CT scan is concerned in pediatric patient undergoing correction for genovalgum. And we studied 18 patients with genovalgum to answer this question. And a few of the patients I'm happy to put before you. So this is a 14-year-old girl with genovalgum, and this is the data from a supine CT scan. And this is the data from a simulated weight-bearing CT scan of the same patient. So are these data same or different? And when we compare the data, we realize that some of the data are same. For example, distal femoral angle and the proximal tibial angle, they tend to be same. So these are the bony parameters. However, the tibiofibular angle, the joint line congruence angle and the mechanical axis deviation that changed between the supine CT scan and simulated weight-bearing CT scan. Another patient here which had lower femoral and upper tibial valgus, we found that on simulated weight-bearing CT scan, the data were different. The tibiofibular angle, the joint line congruency angle, the mechanical axis deviation all changed in this patient. Again, in this patient, comparing the data, a huge difference in these angles, and the maximum difference was found in joint line congruency angle. So the changes were seen in tibiofibular angle in these patients, and they varied from 4% to 97.8%. So there was no correlation between the severity of the deformity and the percentage change in the angle. There was no correlation between the weight of the patient or.
Yes, paper is open for the discussion.
Taral, how these images were simulated? No, what do they do in simulation exactly? Can you tell us?
Yeah, absolutely. So this software is known as Rhino 3D software. And what we did is we picked up the segmentation from a supine CT scan. So you have a femoral segment and a tibial segment, and they were matched with this software onto a standing scanogram. So you take a standing scanogram, which represents the standing anatomy of the lower limb, and then you superimpose these 3D images and rotate it so that the bony contours they match. So it's a little complicated process, but that's that. In that way, we were able to simulate how the CT scan would look like if it was done in a standing position.
Does it take in consideration the ligamentous laxity? How
So whatever,
freedom.
yeah. So the changes which have been seen are because of ligament laxity. The changes in the ligament. The second factor which causes changes between supine and standing is rotation. So all of us know that ligaments play a role. So varus or valgus can increase or decrease, but at the same time, more importantly, the rotation also changes, and this made a difference. And in fact, on pedipod group, if you remember some time back, Mangal spoke about external rotation of distal femur in people who have genu valgum, and that changes the angle of genu valgum correction. So these are subtle differences which do occur, with change on weight bearing, and that's why we need a 3D data and a data in weight bearing position. So hopefully this is a work in progress, and we'll be able to give you a very simple solution in time to come, by which you can upload your 3D CT scan, upload your scanogram, and you will get all the figures, and that will be helpful whether you're correcting deformity using a computer or just manually with eyeballing. This data will be important for us.
Yeah, Sandeep.
Good work, Taral, but I just wanted to know what different information what, because you can do
If you are not audible.
Sandeep, you can type. I will answer. Type.
Can you hear me?
Yeah, now it's okay. Yeah.
You can do a supine scanogram and you can do a standing scanogram. What?
Sandeep, remove your microphones. You are not audible.
Please answer the question.
Yeah, I'll answer this, Sandeep, later on. If there are any other questions, please ask.
Does the rotation of the limbs or the position of the limb is same in CT and standing?
So that is corrected. Yeah. So we match patella to patella and correct, because whenever you do a CT scan in supine position, both limbs are externally rotated. That's how it happens in a CT scan. So even these rotations we had to correct in the software when we superimposed it on a standing scanogram. So this technology we have used for several applications. Whereby we have used it for a planovalgoid foot in CP to get a standing scanogram. And
yes, Sanjeev, please.
Yeah, sorry. Hi, Taral. Nice presentation. I don't want to bust the bubble, but so I'm sure you've taken into consideration the radiation cost and the expense. Do you really think that this is worth the effort? And I'm sure this is going to go somewhere, and it's great technology, but practically speaking, do you think it's going to give you more information than what you would get from a good clinical exam and a good standing plain X-ray?
So good clinical exam and standing X-ray are not going anywhere. They are here to stay. Since we were using a 3D printed guided technology, we had to obtain a 3D image. And you cannot convert an X-ray at present onto a 3D image. So the only way to obtain a 3D image was a 3D CT scan. What we have done is we have done a protocol, the same protocol which is used all over the world, where we use a low resolution CT scan, and we do only proximal femur, distal femur, proximal tibia, and distal tibia. So we don't CT scan the entire lower limb. And so only parts are scanned and the rest of the parts are simulated and they are generated using a software. So we've been able to minimize the radiation of a CT scan to that of 3 X-rays, if I have to quantify.
Perfect. Thank you.
Yeah. Fine. So if we don't have any more questions, still we have 2 or 3 minutes left. So any or like audience wants to ask any questions to any speaker, we can utilize those 2 or 3 minutes.
So I just wanted to make a comment then, Dhiren bhai, is that this same technology is useful for many applications now. When you have a plano-valgoid foot in CP with deformity which is difficult, and a 3D cannot be done because it's not weight bearing. So now you can have a weight bearing X-rays and a supine CT scan, and you can superimpose those images onto the X-ray and get a 3D model. So if anyone is looking into this, hips, for example, we take supine hip X-rays and treat hips which are supposed to be walking and weight bearing. Now we had a big session on CP today. So these changes can be simulated now when we have a tool available. Thank you.
Okay, thank you. I thank the chairman of the session, Dr. Sanjay Balke, and Dr. Damodar for chairing the session. And we move on to the next session. For that, I invite Dr. Ramani. Dr. Ashok Johri is not well, so he will not be able to join us. But Dr. Ramani and his colleagues will.
Good morning, Dhiren. So Dr. Johri and I, we organized this whole session by inviting the case presentations from various speakers all across the country, so younger orthopedic surgeons relatively. And we got about 19 case presentations, out of which we shortlisted 6. So there are 6 speakers who are going to be presenting their case presentations, and we will have 5 minutes of case presentation followed by 5 minutes of discussion. And that is how it's going to happen. And just a second, let me try to share the first speaker. Dr. Venkat Das is going to be speaking. This is the first speaker. So I invite Dr. Venkat Das.
So we can share at our end, if you don't mind. Ramani sir.
Yeah.
We can share from our end. Ashok here.
Yeah.
Okay.
So can I stop this?
Yes, sir.
Yes, I'll just start sharing.
Yeah, go ahead, Mike.
Okay, just a second.
Good morning, everybody. I thank the panelists for giving me this opportunity to present my case in this forum. So this is a 15-year-old boy who presented with pain in the left hip following a trivial fall. And he was wheeled into the emergency room with his limb completely in external rotation, and he was just not letting us to touch the left lower limb for even clinical examination. And he was obviously not able to walk. And looking at the X-rays, we know that he has got an acute unstable slip capital femoral epiphysis, and the management of which is even today controversial, and we have multiple options. So in situ screw fixation, just keeping the limb in the same deformed external rotated position and putting a couple of screws inside the epiphysis is one of the options, which is being practiced in many centers. And gentle reduction or a positional reduction and screw fixation is the next option. And of late, modified Dunn's procedure, where we open the hip through a surgical dislocation approach and realign the capital femoral epiphysis, is the other option of treating this unstable slip capital femoral epiphysis. If you look at the treatment trend in the history, we can divide basically into 2 different eras. One is before modified Dunn, and the other is after modified Dunn. Before modified Dunn, there is actually 2 groups. One is in situ, the people who used to do in situ fixation, versus vast majority of those who did the positional reduction or gentle reduction and screw fixation. But after modified Dunn, we do see that the people who do modified Dunn is steadily on the rise, and the number of people who are giving up a positional reduction is on the rise for this reason. And we came to know about this through our survey, which we conducted a couple of years back. So is there a role for reduction in slip capital femoral epiphysis, which presents as an unstable slip? So this is a paper by Randy Loader in 2006, in which he mentions that this unintentional reduction does not seem to increase the risk of AVN. And this is a more recent paper which was published in 2021. where they have studied 43 unstable slips where they have done purposeful closed reduction and pinning. And they found that their AVN rate was 26%. And they argue that it is not different, or there is no increase in risk of AVN compared to an in situ fixation, which equally has the same, or roughly the same amount of avascular necrosis. So how do we manage? So we do what we call as the controlled repositioning, where we carefully reposition the limb to gently to reduce the slip, if at all it is reducing. And this is a gentle internal rotation maneuver, and then we take a cross-table lateral view, by which we believe that we convert the severe slip to mild slip, and we do not aim to get anatomical reduction. If we don't get the reduction, then we are prepared to do a open reduction by a modified Dunn's approach. So in this particular case, I was able to get a position and repositioning, and then we fixed it with a single fully threaded cancellous screw. And you can see that there is a bump anteriorly, and this FIR was -5 degrees. So in this situation, we opened up anteriorly and we did the primary osteoplasty to increase the FIR to +20 degrees. And his post-operative period was uneventful. We kept him non-weight bearing. And this is the X-ray. And at 6 weeks, we started him, this is the X-ray at 6 weeks, which looks good. And we started him on partial weight bearing walking at this point. At 3 months, so this was the X-ray when he came to the clinic for follow-up. He started full weight bearing walking against advice, and he got the screws to break. So this is a OMG situation, and I was really worried what to do. So the options are to put another screw and stabilize the slip in the same position, but there is no corridor. I mean, there is no way that I could get a screw inside the epiphysis to hold it steady. One more option is to wait and see whether the slip, keep him non-weight bearing for a prolonged period of time and see whether the slip heals if you are lucky enough. And the other option is to remove the screws and reduce the epiphysis and fix it back, which could be really challenging. So we opted for a modified Dunn's procedure. And the challenge was that the hip was healing. There was a lot of callus formation, and the broken screw was spanning across the physis into the neck. So we had to struggle to remove the screw, and then we realigned the epiphysis and fixed it in this way. At 6 weeks, it went on to heal well, and this is the 3 months X-ray. You can see the complete healing of the physis. And luckily, he did not develop AVN, and this is the 1 year follow-up X-ray where he's doing well. So what did we learn from this case is that one screw may be too less for an unstable skiffy. Even though you keep non-weight bearing, some of the patients are need not follow your advice, and they may start full weight bearing. So it is always safer to use 2 screws, and we made a change of protocol after this patient that we started using 2 screws. This is yet another case to show that how we use 2 screws for the same unstable slip, fixed with 2 screws, and then primary osteoplasty. And this is a 6 months follow-up. No AVN, and the slip has healed well. The take-home points are unstable skiffy, 1 screw may not be enough. You need to pass 2 screws. And you have to re-emphasize the importance of non-weight bearing walking to the patient. And the role of primary osteoplasty is still questionable. We need more evidence to support it. Thank you for your kind attention.
So thank you very much, Venkat. So we have 3 dynamic pediatric orthopedic surgeons as panelists. One is Dr. Jayant Sampath, one is Dr. Sandeep Patwardhan, and Dr. Taral Nagda. So one quick question to Venkat. I saw, Venkat, that you're not using the fracture table. Do you use translucent tables to pin slip? Are you there, Venkat? Yeah. Venkat, are you there? Hello?
Oh, that was just a recorded talk. I'm not sure if...
No, Venkat is supposed to be there to take the questions. So Venkat, are you there?
He's finding the broken screw probably. So Jayant, you can answer that. How do you do
Sir,
it?
he's present in the as a panelist, sir.
So, all right. So what I'm going to do is I say the question goes out to all the 3 panelists here. So my question to you is, how would you approach this this particular slip, the unstable slip? So, and where does the modified Dunn come in the scheme of things? Where would you use it? So can I start with Sandeep first? Sandeep?
Yeah, can you hear me?
Yeah, so a little difficult to hear, but it's all right. Yeah.
Is that okay? Is that better?
Yeah, that's okay. Just carry on. Yeah.
All right. So my approach to acute unstable slips has been of doing an anterior approach and a subcapital cuneiform osteotomy. to resect bone, a combination of going the Parsh way, decompressing hematoma and shortening the neck.
All right. Okay. So,
And then I reduce it with a similar maneuver and use 7 mm screws, fully threaded. And if the neck is wide enough, I will always add a second screw.
all right. So, Jayant, what about you?
I also do an anterior approach. So after I've done the approach, I look at whether there is obvious mobility at the physis, and under direct vision, I try to internally rotate the femur to see that whether a gentle positional reduction can be achieved under direct vision. And then if that can be achieved, if the slip is that unstable, I can just get a positional reduction and pass 2 screws. I use 6.5 fully threaded screws.
Do you do this in a fracture table?
No. I do it on a radiolucent table, and I do my in situ pinnings also on a radiolucent table. So the trick to get a lateral view is to pass the external fixation connection tube, the hollow tube that we use in a standard XPIC set. So you pass that over the guide wire or the drill, and then you can basically prevent the guide wire from getting bent by the fascia lata. So that's the way to get a lateral view without using a fracture table. Okay. So if there is instability, obvious instability, then I do a cuneiform osteotomy through an anterior approach, just like Sandeep described.
So are you worried about actually getting the reduction? Like Venkat just pointed out that there are papers which suggest that even if you do a little bit reduction, probably the damage has already been done when the actual slip occurred. Do you believe in that?
Yeah. So even Randall Loader has said clearly that in an acute unstable slip, AVN will never be a never event. You will always have an AVN.
All right. So let's shift to Taral. Taral, what do you think?
Yeah. So you're quoting Randall Loader from 2006. It's like, putting 2014 election results and applying them to 2022 in Uttar Pradesh. It's not going to happen. So, an old paper you cannot quote now. So what Sandeep and Jayant are doing, it's like playing blind rummy. You don't know your cards and you are just playing it blind. It's much better to open up and see the vascularity. Whatever is supposed to be an acute slip has a chronic history behind it. And there is always some callus formation which kings the vessels. So I would always do this as a safe surgical dislocation, an unstable slip. Go down, see for yourself, check the vascularity, do the flaps, because that improves the chance of viability of the head. And, when you're doing it in a safe surgical dislocation approach, lateral X-ray is not a problem because everything is under vision.
All right.
So that was my point.
Understood.
The second quick point.
Yeah. So primarily you will be using a modified done in such a situation. Yes. That's what you're telling us.
So if we can counter that.
Yeah, we don't have too much of time, Sandeep. So what I'm going to do is I'm going to wrap it up. So I would say that, there are lots of people, because they don't have too much of experience with modified done and other techniques, they would still try to effect reduction and do a pinning in situ, but a mini arthrotomy and 2 screws at least is important to fix this. A modified done would come into the picture if your reduction is not even to grade 1, or if you have not got that much of reduction. So you are pretty sure that an FAI is going to be a big problem for the patient, then you counsel the family and go ahead with modified done. That's how I would look into it. Let's go to the second paper.
Good morning, everybody. So I have nothing to disclose. Permission has been obtained to use the clinical images and radiographs. So I'm going to take you through a case, a 14-year-old male who was a known case of polyostotic fibrous dysplasia with craniofacial pelvic lesions and lesion in the left femur. The child presented in 2017 with pain, progressive deformation of the left thigh along with difficulty in walking. This is the radiograph. You can see the global lesion in the proximal femur, and also you can see that there is a cortical breach in the proximal femur. So what was done? The child underwent an osteotomy, deformity correction and stabilization with a 12-hole LCDCP. So this is how it was stabilized. And this is 3 months after surgery. You can see that there is lysis around the proximal screw. And this is about 5 months after surgery, where you can see that there is a gap between plate and the bone, as well as there is progressive varus deformation. This is almost a year after surgery. The child had a trivial fall followed by inability to walk, and you can see that there is a fracture at the end of the plate. So what went wrong here? So if you through the articles and literature, so there are two main aims in fibrous dysplasia of proximal femur, that is re-establishing the mechanical axis. But if you see here, we are not able to re-establish the mechanical axis here. And the second thing is regarding the implant choice. For pathological fractures, fixation with an intramedullary nail provides the best stability. And it's always advisable to use an intramedullary nail if possible. But here, a plate and screw has been used, a conventional one, where you don't have the quality of bone that is required for a stable purchase. So the pullout is going to be inevitable. What if locking plates and screws are used? And they can be used at some situations, but it's not going to be equivalent to a rigid locking nail. Also, the length of plate, you can see that the length of plate is short and it's bound to fail here. You have to use the longest plate that spans the whole bone. And if possible, you have to take purchase into the proximal epiphysis, which is relatively spared compared to the metaphysis and diaphysis. So what was done? Again, the child underwent an open reduction internal fixation with a longer plate here and had also zoledronate 3 months after surgery. So this is what was done. And he had a fall again, and surgery was done in the same place, and was referred with this X-ray. The implant was removed. So what are the issues here? There is a pathological fracture in the proximal femur, the quality of bone is compromised, and the mechanical axis is not good. And also the dreaded complication of avascular necrosis of the proximal femoral physis is present, epiphysis. So what was done by me here? So you know that rigid nailing is the implant of choice, but here doing to the short proximal fragment. So what I did is, due to the short proximal fragment, what I did is I decided to go with an angle blade plate, a longer one, which is the implant good in my hands. So I used 2 guides to take purchase in the proximal femur and reduce the fragment, and I used a blade plate in the proximal fragment. The upper guide wire is used to ream and insert a stirred fibula graft as shown here, and then we went for valgus osteotomy. So this is how it was stabilized. We have re-established the mechanical axis. The blade plate is in place, and this is the fibula that is sitting inside. So once the osteotomy site healed, so we used a bisphosphonate because bisphosphonate therapy is beneficial in children with fibrous dysplasia, and also in avascular necrosis, it preserves the bony architecture by reducing resorption of the necrotic bone during revascularization. So here I did an intralesional infiltration of bisphosphonate also into the inferior part of the femoral head, and this is almost 1.5 years after follow-up. So the child was kept non-weight bearing for some time, almost a year, and this is after 1.5 years. You can see that the fracture site has healed, the osteotomy site has healed well, and there is revascularization, and the fibula is also still present. This is the mechanical axis, and this is the modified Harris-Hip score, which is 98, excellent, and this is the functional status after 2 years. The child was kept for exchange nailing, but was not willing at this point of time. So learning points: choose your implant prudently according to the pathology, and bisphosphonates do have a role in fibrous dysplasia and avascular necrosis. Thank you.
Thank you very much, Nirmal. That was a very interesting paper. So I'm going to, if Nirmal, are you around?
I'm here, sir. I'm here.
All right, good. So I'm going to ask you the obvious question. Why didn't you use the IM fixation the 3rd time on?
Yes, sir. The plan was to go for a stage fixation. First, to establish the mechanical axis using a blade plate, which I found that it has a good control over the proximal fragment. And to go for an IM nail once the osteotomy heals, actually. But the child already had 4 surgeries, so he was not willing for a conversion late. I tried to pacify him, but still the implant of choice is a rigid nail.
All right. So as long as that goes across, that the best in the background of a fibrous dysplasia, an intramedullary nail gives you the best construct. And second thing is the use of fibula. Do you think a cortical graft has a better chance of holding on in the background of fibrous dysplasia?
So according to the literature, whatever graft you are going to use is going to be eaten away by the disease process. Yeah, in time actually. But what we found is in this case, there is a lot of bone loss in the proximal aspect. So we thought fibula would be a good stirred graft for time being till it unites. So the aim was first establish union and then to think about the disease actually.
All right. So let me invite Jayant. So Jayant, do you have any comments or questions for Nirmal?
Not really. I think.
All right. Okay. Okay. So
can I ask one question to Nirmal?
All right. Go ahead.
PN Gupta here.
Yeah. Go ahead, PN.
Yeah, Nirmal, you said you did an intralesional bisphosphonate for the femur shaft.
Yes, sir.
So is it like a recommended method? Because considering the fact that this is a generalized disease, will the bisphosphonate will be able to reach the targeted area?
So, sir,
is it a systemic bisphosphonate which is?
So, sir, even the bisphosphonate use is still off-label use. Actually, it's not. There are still a lot of controversies. But as per our experience, we were able to. So what I do is I just put a dye inside the lesion whenever I do intralesional bisphosphonate to see whether it spreads actually. If it spreads, I use an intralesional. Otherwise, I go for the intravenous route.
All right, great. So Sandeep, you have any questions?
Yeah, just a couple of things. One is that for a neck femur region, a graft is recommended for mechanical stability for a short period, though it does get resolved. And the indication of bisphosphonate in avascular necrosis, intralesional, versus a systemic disease like fibrous dysplasia is totally different. I don't think that bathing it in bisphosphonate has the same effect as putting it in bone when there is AVN. Totally different. I don't think we can use this indication there and hope that it works.
Point taken. So Taral, do you have anything to add?
Just one thing to add. It's very easy to talk about intramedullary fixation, in fibrous dysplasia. The problem is in fibrous dysplasia, which is polyostotic, the femur is short, and that size adult recon nail, which is rigid, is just not available. So your only choice is to customize it. So you will have to go for a customized recon nail, which will fit the patient's size and the diameter, and the neck shaft angle. So that's one solution. One of the solution, Nirmal, you still have is you have blade plate in place, and if you want to prevent a fracture at the end of the plate, you can put a elastic nail from side of the nail proximally from the trochanter, let it go down into the distal femur. So if you can put elastic nails negotiating the plate, it will protect your proximal femur and distal femur. So 2 nails you can put still.
Okay.
Adolescent nails are available, Smith and Nephew, which have recon option. They can easily be used. We use them in pediatrics.
We have A2FN nails, and we can put screws inside the neck also. So let me wrap it up. So basically, what is important to understand is that intramedullary fixation is the best bet for a solid construct in the background of a fibrous dysplasia, especially in weight-bearing bones like femur. And it's important to combine it with pamidroninates. The choice is yours, and make sure that you have a skeletal survey or a bone scan, which also takes care of looking out for other lesions elsewhere, which you do not want to miss and get embarrassed. So let's stop at that, and let's go to the third speaker. Dr. Viraj, I invite you.
Good morning, everyone. I am going to present distal forearm fracture. So this is a 11-year male child who had a history of fall from the bike. VVIP patient, son of chief of CRPF, national head over here. And then he presented with this fracture. Now with this X-ray, what are the different options which are available? Whether one should just apply a plaster, or somebody may think of manipulating and then applying the plaster, or somebody even can think of the surgical option. And what was done, he was operated by one of my colleagues in emergency. So my colleague did the open reduction, and then he tried to fix it by putting the nail and just cerclage wire. The nail was taken out after 3 months, hoping that the fracture will unite. But that is not the case, right? If you can see, there is a non-union which is setting, the radius is going shorter. This is at 4 months, you can see the radius has been shortened to a great extent, and there are no signs of healing. And this is at 6 months. There is a frank non-union, a lot of scarring, and then there is a shortening, there is a radial deviation, and movements are really painful. Okay, so that is the, now this was the time the child was referred to me. So now what is the solution for this non-union and then the radial shortening? So I decided to reduce it openly and then fill the gap with the help of the iliacris graft. So I just opened a fracture. See, there was tremendous scarring which was there. And then if you see the bony ends, they were completely obliterated. One can see, right? So first I opened the bony ends by doing the drilling. This is a classical of whenever you are dealing with any non-union. So you open the medullary canal, so you are increasing the chance of union. And then what I did, I took the iliacris graft and it was shaved, and it was shaped like a radial shaft. And then a drill hole was made as if it will act like a medullary canal. Now this graft was put where there is a gap. So bony ends were distracted and the graft was put to fill the defect. So now here the graft was put in between these two ends, and the graft was stabilized with the help of a plate. This was a recount plate which was used, and this is a post-op closure. So you can see this is a post-operative X-ray, and this is immobilization of plaster till the fracture is united. And this is 2 months and this is 6 months. You can see it started uniting. This is 1 year post revision surgery, and this is a follow-up. This is post implant removal, and this is a 3-year follow-up in this child, right? So what does the literature say? Was there really a need for surgery in this fracture? If you go into the literature and see, even at this age group, 8 to 12 age group, even the 30 degree of angulation is still can remodel. You can accept it, and over a period of time, it can still remodel. And there is enough literature to support that. There is a good paper in Orthopaedic Scandinavia also, in which the Friberg has given actually the how much degree it remodels, and for 30 to 35 degree of residual angulation, it will take some time, but it will completely remodel. So the take-home message is: do not take hasty decisions. Do not deviate from the standard principles. We all know that there is a good remodeling potential in the pediatric age group, and if at all you get an onion, then grafting is still a gold standard. It works if you do it carefully and by taking all the precautions. I thank you all for your kind attention. Thank you so much. Thanks to Dr. Zohri sir and Dr. Ramani Narsihan for giving me opportunity to present case in this in this session. Thank you.
Thank you, Viraj. What I'm going to ask you is, so if you had been there when the patient presented, if you had been there, would you have done something different? So the way would you have treated this conservatively and not operated at all?
Well, I may have just manipulated, but still conservative management, just a plaster.
So what was the age of the patient?
He was 10-year-old.
So 10-year-old with a short oblique fracture, which has a tendency to telescope, or rather bayonet, and probably so you would have. So let me put this to to Sandeep first. So would you have treated this conservatively or operated?
So my indication, if there is a concomitant ulnar fracture, is to be as conservative as possible, because there is symmetrical bayoneting and shortening, and sham reductions, as you have seen the paper from Hawaii, works equally well, and you don't really need to reduce.
So but this was a single.
Yeah, but an intact ulna with an oblique fracture can be a bothersome problem. I have my own technique where I make a small drill hole in the metaphysis and bend a K-wire like an elastic nail and introduce it just up to the mid shaft. We don't go right up, but a close manipulation, close reduction with a pinning, not an open reduction.
All right. So you're going to put a pin and you're going to operate, but you do a close reduction and
Closed,
you want to maintain the position.
The
and,
length of the radius
avoid,
especially.
absolutely.
Yeah.
So what about Jayant?
So this is a short oblique. This is what we call a reverse oblique fracture. And if you insert a nail, intermediary nail, from the radial aspect, it will actually distract the fracture. And that's what's happened. That's what's resulted in the non-union, in addition to the open reduction. Open reduction should be rarely undertaken in distal fractures. This is for these fractures, if they are unstable, like what Sandeep said, it's better to insert the nail from dorsally. So the dorsal nail and inserted halfway up the shaft, I think, will actually cause the two fracture ends to oppose together. Whereas if you put it from the radial side, it will distract.
So do you think that there was enough space between the physis and the fracture line for you to introduce the nail in this particular?
From the dorsal side, you will have adequate space to be able to insert a K wire. And I agree with Sandeep that I'd use a K wire rather than a TENS nail.
So you're using a K wire to introduce it inside the medullary canal, not fix the fracture. That's what you're telling us. All right. So what about you, Taral?
Yeah, so I do it little differently, and I prefer an external fixator. The whole idea is to maintain length of the radius. So put two wires between the physis and the fracture. There is adequate space available, and two in the middle 1/3 of radius, and that works beautifully. We've done it in around 3 to 4 patients now recently, and we are going to write it up. Another option for this fracture comes from Vidarbha itself, where Viraj stays nearby, from Dr. Gadegone. From Chandrapur, and he has described a technique where he will make an entry point in middle 1/3 of the radius and does a retrograde nailing from middle 1/3 of the radius where the pronator teres is attached, and then pass the nail down and remove that nail after around 3 months or so. So this is a difficult fracture, and there are different options.
So what we all come to a consensus that we are not treating this conservatively. We want to maintain the radial length and make sure that we don't end up with a problem in at least pronation supination if there is a problem. So to wrap it up again, we have to strive to maintain the radial length whenever there is a single bone fracture even if it is a lower end radius, which has a propensity to remodel very well. And we need to strive for union. And if there is a non-union, we have various techniques. So any of you, you all agree with what was done as far as the non-union was concerned, all three of you?
The one question I had for Viraj is, you've immobilized it in supination for a distal radius fracture after the fixation. Why did you immobilize in supination? And if I can ask all the other faculty, what is their position of immobilization in cast?
Yeah.
Yeah, Viraj, go ahead.
Yeah, Jen, actually, see, it is it is a chronic non-union, so usually as far as the rotation part is concerned, you're not sure about the fragments because there's a lot of fragment, the bone loss which is there. So I preferably, keep these patients in supination so that if at all there is some rotational deformity if we are having, so that can be
Viraj, Jayant, did you have any specific thing in mind when you asked this question?
So, see, typically we would immobilize a middle or distal third forearm fracture in mid-prone or in slight pronation. It's the proximal forearm fractures that we typically immobilize in supination. That is
so when you're talking, this is when you are not fixed it. Then you're not fixed it, and you're treated it conservatively. That's what you're talking about.
Yeah.
So let's stop it at this, and let's start with the next paper by Dr. Gaurav Gupta from Delhi.
Hello everyone. I am discussing my case of complications. This is a 12-year boy, known case of meningomyelocele at the age of 1 year. Came with complaint of non-healing foul-smelling ulcer over the left heel since 6 years. There is no sensation of pain in both his feet. He has tried conservative treatments like contact casting, oral and IV antibiotics in the past, and was operated multiple times in form of debridements, vacuum dressings, but not of much help. And he was finally advised amputation above the ankle joint, which he was not willing for. This was the clinical picture showing non-healing ulcer and multiple sinuses around the ankle. We'll discuss the X-ray shortly. On local examination, there was 5 into 5 centimeter wound with floor of the ulcer covered with necrotic cells. Skin around the Achilles tendon insertion was erythematous, warm with multiple pus draining sinuses. There was sensory neuropathy. Power in the foot and ankle muscles was 0 out of 5 except the ankle dorsiflexus. These were the clinical appearances of the wound. X-ray suggested destruction of calcaneus. MRI showed resorption and sequestration of calcaneus with multiple pus pockets. There was raised CRP and ESR, and pus swab was positive for Pseudomonas aeruginosa. On this X-ray, you can see that the calcaneum is comminuted, resorbed, and radiodense, showing complete sequestration. Broadly, we had 3 options: either to go for conservative treatment again, do a transtibial amputation, or try a total calcanectomy. We reviewed the literature and compared all the 3 methods. Conservative management has got a high risk of failure as it does not address the underlying etiology. There is a need of repeated dressings which can lead to wastage of time and money, and it can lead to persistent foul smelling discharge in case of non-healing or progression of the disease, leading to further progression of infection and destruction. Transtibial amputation, here the foot is completely lost, leading to psychological trauma, social stigma, cosmetic unacceptance, increased energy expenditure due to need of prosthesis, complications like phantom pain sensations, repeated amputations, and limb length discrepancy and limp while walking. The child was not willing for transtibial amputation. Total calcanectomy was a middle path in all the methods. As majority of foot is retained, it conserves energy. As foot is there is a need of orthosis, and the child may need a transtibial amputation in case the surgery fails and the infection persists. As compared to transtibial amputation, the limp is minimal and the limb length discrepancy is minimal, and it is more socially and cosmetically acceptable. We went ahead with total calcanectomy after thorough discussion with the family, and we approached the calcaneum through a modified Gansley's incision as shown in the previous photograph. Calcaneum was removed en masse. There was some fusion with the talus, and so the inferior surface of the talus was scraped. And finally, after thorough lavage and debridement, wound was closed over antibiotic beads, which were filled with antibiotics sensitive to Pseudomonas aeruginosa, view in the pus swab. Still, there was a delayed wound healing due to poor blood and nerve supply, and it took 7 weeks for the wound to heal. Finally, it healed, and the child was able to walk. We gave a customized light, and we made sure that the weight is borne over the midfoot and the forefoot, and there was no weight bearing over the hindfoot to avoid recurrence of the ulcer. This is 6 months post-op video of the child. He is using an orthosis, but he is able to walk comfortably and is presently representing Haryana in interstate cricket tournaments. After repeated requests that he should be living a normal life and not using his limb much, but he is not willing for that and is continuously playing. We were able to publish our paper in Journal of Clinical Orthopedics and Trauma in 2020. I thank you all for your patient listening. Thank you.
Thank you, Gaurav. Are you there, Gaurav?
Yes, sir. I'm very much there.
All right. Okay. So my question to you is, suppose this patient had come to you earlier. Suppose his patient hadn't had, the osteomyelitis of calcaneum, only had a trophic ulcer in the weight-bearing part of the heel. How would you have approached it?
Sir, I would have tried obviously conservative management in form of a contact cast and maybe some debridements and antibiotics, culture and antibiotics at that
So you would have thought about flaps or something like that, isn't it?
Initially, yes, conservative, but if that wouldn't have worked, then I would have investigated further to see if that is going into the bone, and depending upon that, I would have taken a call.
All right. So I'm going to put this question to each of the panelists here, because in a situation with a background of a MMC sequelae with an insensate sole of the foot, with a non-healing ulcer, with a calcaneal osteomyelitis, how many of you would actually opt for an amputation, a SIMS, or a transtibial as the first option? So, Sandeep?
So my take on this is that we have to look at the underlying bony deformity that they have, because unless the bony deformity is corrected and the foot is aligned, the weight-bearing skin will keep on breaking down.
All right.
So I will always try to salvage by doing one attempt at either an external fixator, a JS variety to correct the deformity, or an osteotomy and correct the deformity to bring the weight-bearing axis correct, and then debride the ulcer and keep him non-weight bearing.
No, let me interrupt you. What do you mean by deformity? We have a calcaneal osteomyelitis.
No, most of you asked about neuropathic ulcers because of meningomyelocele, right? They are usually associated with deformities. If it's pure
we are talking.
osteomyelitis,
We are talking about calcaneal osteomyelitis also.
yeah. So if it is non-neuropathic, what he did was fine. It depends on
sensation.
sensation.
It is a neuropathic. It is MMC background. It has a
so without a
heel.
deformity, I will definitely follow what he has done and save that leg. I won't go
So
for
you will do a calcaneal. You will do a calcaneal
and
excision.
save the weight bearing heel.
Save the leg. So you are not worried about a repetitive trophic ulcer which may form because there is a insensate heel. That is the first reason why that particular ulcer actually occurred. So aren't you worried about that?
If the axis is good and there are no deformities, it's unlikely with good protection and taking care of infection, we can buy him time. Primarily, I won't go for him.
The reason why I'm asking you is most of the times it's a S1 if it is involved. It's usually if there is a varus deformity, the patient is putting weight always on the outer border of the foot, which is insensate, and you'll have a lot of non-healing ulcer. But then if you correct the foot, the sensation is pretty much better over the medial and the middle part of the foot, so you get away with it. Here, primarily, we have a problem right at the area where the patient is bearing weight. So then that becomes, when you, even if you do a calcaneal excision, what stops the nature to produce that same kind of non-healing ulcer in the same place later on. So what are you trying to achieve?
Protective footwear, doing a sensate flap are options. Primarily for a kid, I won't go transtibial at the first go. The first surgery will be always this.
Fair enough. So what about Taral?
Yeah. So, there are two aspects to this. One is taking care of the infection and getting the wound to heal. Right. And the second aspect is preventing a recurrence of the same problem.
Remember, there is a calcaneal osteomyelitis also.
Absolutely, absolutely. So both have to be dealt with differently. You cannot combine both in one. For the first thing, debridement and taking help of plastic surgery colleagues to put a VAC. With VAC, what happens? The amount of the dead space reduces, and sometimes you can get a primary healing without doing too much of a procedure initially, but not with the the condition Gaurav was left with. What he did was correct, but with a lesser problem, just a small signal changes in the calcaneum and a wound, you can do with debridement and VAC. In the position where Gaurav was situated, faced with, you have to debride and do an extensive surgery. The next part is going to be more difficult, which is to prevent a recurrent ulceration. And here again comes, our arms or tools are not sufficient here. We have to take help of plastic surgery colleagues to cover a raw area if possible, especially on the heel, weight-bearing area with a thick sensate flap if it's possible. Because this child is going to become, to be active. He's at a level where his other muscles are functioning well, quadriceps is functioning
So
well.
you too will not resort to a primary amputation.
Never.
Even in the when you have a calcaneal osteomyelitis and background MMC with an insensate sore. That's what you're saying.
Conserve.
Okay, what about you, Jayant?
So I would have, as a secondary procedure, the rate of relapse is very, very high because his calf will be very weak and he'll go back into calcaneus again. So if some kind of procedure or tendon transfer can be done to try and keep that heel up and out of the way, I think that would certainly help in addition to long-term bracing. So this child has a very high risk of recurrence.
So you are also not for any primary, even in the background of such a massive infection and insensate foot. You're not in that. So the consensus is that you always go for a conservative management, especially when the family has is not for any kind of an amputation. They want to conserve. So like we all agree that we have to control infection, and it's easier said than done. But in cases of insensate sole and repetitive infections, and sometimes if the family is really fed up, sometimes aggressive approach like an amputation might be a very viable option in order to reduce morbidity and increase functionality. So thank you very much. Let's go to the next paper by Dr. Ritesh Pandey from Patna.
A very good morning to all. I am presenting a case of deformity relapse and residual shortening after centralization in a case of radial club hand. This was a school-going 7-year-old child with bilateral radial club hand. Centralization of both wrists was done at the age of 15 months. Clinically, there was significant shortening of both forearm with reduced forearm-arm ratio. Also, there was a total deformity of 95 degrees on left side. Elbow range of movement were satisfactory on both sides. However, both wrist and fingers were stiff. The child was somehow managing to write with her left hand, but parents were worried about the appearance of limb and wanted something to be done for it. Review of literature revealed that loss of correction and residual shortening are quite common after centralization of wrist, and different values have been quoted in different studies. Some common causes for recurrence includes inadequate initial correction, inadequate soft tissue balancing, premature removal of K-wires, and inadequate splintage after surgery. Moreover, short forearm itself has tendency to deviate radially. Also, a positive correlation has been reported between recurrence rate and severity of preoperative deformity, amount of correction at surgery, and age of the patient at surgery. So we looked further for what can be done in this case, and this study by Kawabata et al. Reported satisfactory results and functional outcome after simultaneous deformity correction and lengthening using Elizarov fixator. The frame used is shown here, which is simple and easy to use. And this is another study from Russia with similar results with use of Elizarov method. So having this much of evidence in hand, we moved ahead and lengthened the right ulna by 7 centimeters without any complications. And we decided not to operate on the left side as the child was writing with left hand. However, within 1 year, deformity on left side progressed 270 degrees and the child was unable to write anymore. So a closed wedge osteotomy was performed in distal 1/3 of ulna to create some space so that Elizarov frame could be applied. Further deformity correction and lengthening was continued gradually. However, after a few weeks, the child started complaining of pain around the wire in metacarpal, and the X-rays revealed loosening and migration of wire. So the wires were exchanged and additional ring was added for hand to get better stability. Further course was uneventful and satisfactory deformity correction and lengthening was achieved. So at the end, we achieved 7 centimeter length on right side and 5 centimeter on left side. Complete deformity correction and equal forearm length on both sides. Preoperative elbow movements were preserved and there were no significant complications. And above all, the child resumed writing once again. Hence, to conclude, recurrence of deformity and residual shortening is common after centralization procedure. This may be severe enough to justify surgery, and these objectives can be achieved satisfactorily with the help of Elizarov technique. Thank you very much for your kind attention.
Thank you, Ritesh. Just to this case was mainly to stimulate some discussion. So, Ritesh, are you around?
Yes, sir. Good morning, sir. I'm here.
Good morning. Okay. So, I understand that this patient came in late, came at 7 years with a recurrence of the deformity, and of course, shortening is what one expects. But did you consider policization at all at that particular point of time?
No, sir. As mentioned, actually the fingers were stiff and the movements in the index finger was not very good. So we didn't think of the policization in this case.
So I just put this across to the panelists. Taral, so at this age, when this patient comes with a relapse of the deformity and probably got used to what she has, would you consider policization at this point? At any point?
Not at that age group. It works well in a younger child.
Right.
But at this age, I would do similar to what Ritesh has done, but without the Elizarov fixator.
All right. So what about you? What about
centralization?
Understood. So what about
centralization works, but at this age group.
Yeah. So Sandeep.
At this age group, the distal osteotomy of ulna.
Yeah, Sandeep.
Yes, Sandeep.
Yeah, I agree to what Taral has said. Policization has to be done before 18 months of age because cortical representation of the thumb is lost, and in older children, policization really doesn't add value. Deformity correction, yes, provided they have good elbow flexion, is what one should remember, because you are taking, especially in bilateral club hand, if they can reach the mouth with the club hand and you may take the hand away, they can have a problem. Significantly, they cannot eat. So you must be sure that elbow flexion is adequate, because sometimes they don't have elbow flexion and correction at a later age may be difficult and make the child worse. And third point is that most papers have shown that the recurrence can effectively be only prevented after 10 years by doing a epiphysiodesis between the distal ulna, sparing the growth plate and the central carpus by making a notch and putting the wire. Otherwise, about 25% recurrence is to be expected.
Understood. So policization, sometimes just a point, policization doing before 2 years of age can be very demanding at times, and sometimes, because I do it along with a plastic surgeon, we prefer to do it sometime around 3 years of age, and it has worked well for us. So as far as we are concerned, we probably, if the patient comes to us early, we would start with the standard manipulation casting, get it to in a decent position, think about centralization between around 1.5 years, before 2 years, think about policization around 3 years, and think about lengthening as late as possible, depending upon the requirement of the family. So, what about you, Jayant?
So
in this particular
recurrence is the rule. After centralization, over a period of time, there will be some recurrence. And I give a lot of importance to how flexible the residual deformity is. If a lot of children prefer to have a mobile but slightly deformed wrist rather than a stiff, straight wrist. So in this particular child, I agree something had to be done because there was a very significant recurrence of deformity. But you are not aiming to have a completely straight forearm and hand. Slight amount of deformity, but with good flexibility, so that they can use the tenodesis effect of the wrist to get better grip strength, whatever available grip strength is there. So function is the most important determinant rather than a radiographic analysis of the problem.
Yeah, exactly. So suppose this centralization had worked wonders and the hand was absolutely straight and you were following this child, when would you think about lengthening as a more of a cosmetic procedure?
I rarely offer lengthening to these children, particularly the bilateral ones. They are well adjusted. The unilateral ones, I have had nothing but problems with lengthening. So I think they are very demanding procedures, and you end up with very stiff fingers also when you lengthen these radial
So
club hands.
what are your thoughts about policization in general?
Exactly the same. Before 2 years of age is the preference of the plastic surgeon I work with.
Okay, thank you very much. So let's get on to the next speaker. And Ashok, can you hear me? The last talk, I think there is a problem in the last part of the talk. So if you are okay, I can share the screen and
yes, sir, you can share screen.
So the last talk was a issue. Just a second. Let me.
You can go ahead and share your screen.
All right. So let me share this. Yeah. So Mandar, are you there? Otherwise.
Yes, sir. I'm here. Sir.
Okay. Okay.
We can't see the video, sir.
Can you see it now?
No, sir. I think you have to open the video first and share the video, not the screen.
So you'll have to unshare the screen first and then share.
Well, so are you able to see the screen? No.
No, sir. You open the video on your desktop and then share that video.
Okay, just a second. All right, there's something going on. Just a second.
Mandar, you have the final version. You can.
All right, so let's do one thing. Shyam, why don't you share the video and the last part about Mandar, the last part about their top-up thing the plastic surgeons did, you can explain. All right?
All right. Sir.
Okay. Sir.
Okay.
Sir,
okay.
Can I share the screen then? Otherwise, that will be easier.
Yeah, go ahead, Mandar.
Yeah, you can share. Yeah, you can share. Why not? Yeah, go ahead.
Share the audio also when you're sharing.
Yes, sir. How do I share it?
Just play it.
I'll just play.
Yeah.
I would like to discuss my worst case, my worst complication in a simple forearm fracture in a child. This was a 11-year-old girl, had a fallen outstretched hand, came with severe pain, swelling in the right forearm. As you can see that she has deformity, she has a significant displaced ulna fracture with an undisplaced radius fracture, for which she was planned for TENS nailing. However, unfortunately, intraoperatively, what I
Don't mute yourself, Mandar.
Okay.
The radius was looked quite undisplaced, so I conserved it. This is a day 1 post-op X-ray. You can see that it has a good opposition and the radius was well aligned. Day 7 post-op, I could see that there was some malalignment of the radius, but I said that this is okay. Day 14, the malalignment increased. She came back after 3 weeks. That time, unfortunately, I was not there, and my fellow gave a cast in supination, as was the rule at that time. This was the X-ray at 28 days, about 4 weeks. As you can see that the child had a forearm in supination, but there was this 90-degree malunion as per the crossover sign. The cast was removed at 6 weeks. The parents were very happy because she was able to supinate. As we know, Indians require supination. Some deformity was seen, but she was able to do all routine activities. She was unfortunately lost to follow-up at that time. The parents used to send me messages that she is doing fine. She was back to sports after about 6 months. After about 9 months post-op, I got a call from her dad saying that she has fallen down from a horse, and has the same deformity. So she came back, this was the deformity. As you can see, there's significant deformity in the forearm. And the X-ray showed a grossly deformed forearm. Probably there was delayed healing or non-healing of that fracture. And the nail had bent. So what I thought, I'll do open reduction and plating and removal of the nail. But what I could see was as soon as I was aligning the fracture, it was going into severe amount of malalignment. So I thought that God has given me an osteotomy, why not correct it now? So I de-rotated it and fixed it with a 3.5 mm LCDs. As you can see that there is very good alignment, there is this translation which was intentional, and because of which I could get an excellent radial bone. However, what had happened was because of the significant rotation, derotation, the closure was extremely difficult. So after taking suture, I found that they were too tight. So I kept the radial wound open and closed the ulnar wound. I thought that I'll come back after about 3 days for later closure. However, after 3 days, I could see that the radial wound was just not closing. Thankfully, I had a very good plastic surgeon with me. So we brainstormed. We thought, this is a very large wound, exposed implants. This is a corporate setup. The bills are rising too much. So what were the options? We thought of VAC, but again, that will be too lengthy, unpredictable with exposed implants. Flap, we thought that even the thought of doing an abdominal flap in her was very scary, very big family, the typical dialogue of ladki hai, kya kare. But any other option. Thankfully, my plastic surgeon was excellent. He had something known as a top closure device with him. Well, this top closure device is basically 2 or 3 sets of plastic attachments, which are to be attached on the sides of the wound, where they can be sutured by multiple sutures, and that helps in distributing the stress across the entire skin, and that can help in good approximation. There's just one article about this in 2012, but this just worked wonders. As you can see, that these are the top closure devices through which thick sutures were taken, and just approximating stay sutures were taken here. Lo and behold, after 21 days, the wound had completely healed up. This is the 3 months post-operatively wound picture. Excellent healing of the wound, excellent scar also. And this is at 18 months post-op. As you can see that the fractures also had healed completely. I thank you, and I would like to have some opinions regarding it.
Thank you very much, Mandar. That was nice and very interesting way of closing the wound, because every one of us has faced this problem one time or other. So my question to you is, when you actually saw the, the initial time when you saw the particular the medullary canal being very thin and sclerotic, did it ring any warning bells? What do you think was the problem?
So again, I'm still at a loss of words about what.
Did you investigate? Did you investigate? That's what I'm asking.
So the only thought of what I thought of was some form of tardy kind of radioulnar, pseudarthrosis, kind of sclerotic kind of pseudarthrosis at that site. But again, that is something which I still don't know why it happened.
Did you do a skeletal survey?
I did a skeletal survey which did not find anything else except for probably symmetrical amount of sclerotic canals on the other side, which again I could not find any reason for.
All right, Sandeep, do you want to comment?
No. My only comment is that sooner or later you're going to remove those plates. I'm worried about the refraction when the plates come off.
Sir,
what do you think, Sandeep? What do you think, Sandeep, was the cause for this kind of delayed union?
A single bone fracture which is nailed, and the other one, the radial one with
Sandeep, you are audible.
Your voice is quite unclear a bit.
Sorry, I think I went out for a moment and my Bluetooth has got disconnected. Carry on.
Yeah, okay, that's all right. So let's get in Taral here. My point is, Taral, would you, after when you when you see that kind of a situation where the medullary canal is sclerotic, you think that there is something going to happen, maybe the bone is not going to heal. Would you have done something different in the first go, Taral?
No. I think single bone fixation of a forearm fracture is a valid treatment method. I would have done the same thing. rather than opening and putting a plate. So what Mandar did on day one, fix one bone with K-wire and left other one to be supported by the other bone. Single bone fixation. It's a valid method. I would have done
most of us would have done the same, right?
Yes,
so what do you think the problem was? What do you think the problem was?
No, it's just the quality of bone. It's a narrow medullary canal. Some pathological bone, really difficult to quantify because this should have healed. It has not healed because of a biological reason. The second point I want to convey is in the derotation osteotomies of the forearm, which I have done. Initial 2 cases, we landed up with the same problem, wound being opened up. And nowadays, what I do as a prevention, don't take a straight incision when you are derotating. Take a S-shaped incision so that when you close, it becomes straight and it easily closes. So you have to anticipate that and do it. And third, I want to tell Mandar a friendly advice is that if you do implant removal ever, Sandeep is advising not to do it, but if you do it, do one bone at a time. Don't do both bone plate removal at the same setting.
Absolutely.
All right. So Jayant, you want to add something here?
So I would have, generally for forearm fractures, I'm very careful about getting them back to activity, particularly if I put an implant inside. I always tell them, do not get back to contact sports. So the fact that she fell off a horse the second time, I would have made sure that the patient was not on a horse until I confirmed radiographically, say 6 months down the line. So I'm very, very careful because I've had many refractures of forearm fractures and they're all bad experiences, the forearm refracture. So I'm extremely careful. So that is one message from this case.
So Mandar, did you investigate for vitamin D deficiency?
So vitamin D was low, which was expected. Probably if we get vitamin D of 11-year-old females as a rule, I think 75% of them will have vitamin D deficiency. I treated her for that, but I don't know whether it was a cause for a sclerotic canal or not.
All right, understood. So that's anything else? Anything else you want to add?
Mandar, I want to ask. Hello,
yeah.
Dr. Brahmi.
Yeah, please
so
go
in retrospect, Mandar, if you see your plates, they are a little bigger for the size of the diameter of the bone. So in retrospect, would you have considered using some lesser profile plates like recon plates, which would have actually made the closure a little easier?
Sir, probably, but again, she was like almost a full-grown 12-13-year-old girl.
Okay.
So probably
I thought that the profile of the bone actually.
Yeah, that's fine. Sometimes you do face these kind of problems. You at that particular point of time, you are more interested, especially in a refracture. You are more interested to make sure that you have a good compression and you are putting those plates. But yes, it has been properly dealt with, and something which I was not aware of, this kind of closure technique. So I'm going to be discussing this with my plastic surgeon.
One small point why I wanted this is that we should have our plastic surgeons have that device. It's a pre-packed device. It costs about 20.
No, it's a wonderful device.
It saves a
wonderful. I mean, how much does it cost? How much does it cost, Mandar, by the way? How much does it cost?
A request to
about 24.
Okay. So thank you very much. All the 6 speakers, thank you very much. I thank the panelists, Dr. Sandeep, Dr. Jayant, Dr. Taral, for their valuable contribution. And I'm sorry that Dr. Johri was not here because he's not feeling well. But we all wish him a very speedy recovery. Thank you very much. Thank you, Dhiren.
Thank you. Thank you.
Thank you, and my apologies that I was not present.
Thank you. No problem. That's okay.
So now we move on to the most important session of the program. That's a validatory function. We are not changing the timing. We have 2 hours session even after the validatory function. So please don't leave the Zoom meeting. First of all, I invite the organizing chairman of the conference, Dr. Rajendra Abhyankar, to share his feelings about the conference. Dr. Abhyankar, please.
Good morning, all. Dr. Dhiren, Dr. Sandeep Patwardhan, my senior colleagues and friends. Now that we are at this valedictory function of closure of this conference, I would like to say a few words. COVID has played spoilsport in every nook and corner and everyday life, and so it has done in this conference also. We had we were struggling to conduct this conference since 2019, and ultimately at the last moment had to cancel it. And now we are meeting on I would say a successful web conference 2022 POSICON. My team of Kolhapur Orthopaedic Association, Dr. Sahasrabudhe, Dr. Kotkar, Dr. Sase, Dr. Kriplani, and Dr. Keshwani, plus all the members of the organizing team toiled a lot for last 2 years to make this conference a success. Organizing secretary, Dr. Negandhi, worked day in and day out, and he had a lot of tension arranging it in Goa, then shifting it in Kolhapur, then converting it into a web conference. It was only because of unconditional, continuous support of Dr. Dhiren and Dr. Sandeep Patwardhan and the executive committee of POSI that we could come to this stage of valedictory function of POSICON 2022. All registered delegates, and there were 247 of them, had believed in the ability of Kolhapur Orthopaedic Association to conduct the conference physically, and they were the backbone of our strength in arranging this conference. Mr. Patwardhan of Vama Events was there at every point of time, whether to arrange it in Goa or then shifting it to Kolhapur. And so was Executive Committee of Maharashtra Orthopaedic Association, Dr. Karne and Dr. Gadegone, Secretary and President respectively, who were generous enough to arrange for the MMC credit hours at last moment. My friend Dr. Suresh Deshpande and his team of Ortho Guru and Asavari, they made their platform available for us when we were thinking of hybrid conference, and they were even ready for taking over this web conference and have worked to collect the videos of pre-recorded videos of all the lectures. Dr. Rajiv Negandhi needs a special mention at this juncture. And I think with this, I would like to assure all of you, all the registered delegates, that on behalf of Kolhapur Orthopaedic Association and the organizing team, I assure you that we are going to try to talk to all the vendors to whom we had given advances. Unfortunately, we had to cancel the conference, but we will see to it that we give maximum refund, maximum, which the money which I cannot or we cannot get back, that has to be forfeited as the refund policies which we had decided. But we are trying our level best to get all the money possible back, and we will be refunding the maximum amount each and every one. And I think POSI will be with us in this juncture, and Kolhapur Orthopaedic Association and POSI will not keep a single pie with them, and we will refund the maximum amount which is possible to all the delegates. With this, I thank you again and hand it over to Dr. Dhiren Bhai.
Thank you, sir. Thank you for your delegate-centric approach and your reassurance. And I'm sure that you are going to work very hard for this point also. Like you have really worked hard for the conference, you are going to work hard for this refund policy also. Thank you. So now we move on to the next point, and that's the vote of thanks by our organizing secretary, Dr. Rajiv. Rajiv, over to you.
Sir, on the onset, I would like to thank Kolhapur Orthopaedic Association and POSI for giving me the opportunity to become the youngest organizing secretary of POSICON. And I would like to specially thank to all the delegates who registered and were there on this platform. Some of the registered members did come to the venue, but probably they were unaware about the shift of conference from physical platform to the virtual platform, even though we had sent them the informations on email and messages. So I feel really sorry and I apologize for that. I wish to thank all the faculty members of POSI and especially the friends of POSI who have helped me create this scientific program, and that is why we are here to enjoy this good academic feast today. So special thanks to all the POSI friends, those who have worked with me, and I think we have started this work since 2021 when we were in pandemic, and we gave the shape of this final program near the conference. And again, I would like to specially thank all the Kolhapur Orthopaedic Association members and our organizing team for doing the groundwork and helping me to do the organizational work make easy. Again, I would like to thank all the vendors, especially Vama Events, Ortho Guru, who had given us the platform to do a hybrid conference, and they were ready to do the complete virtual conference as well. And I would like to specially thank Hotel Sayaji for cooperating with us. Hopefully they will continue to cooperate with us and we can get a better deal from them to close the finances. And I would again thank to all the stalls which were ready to be there, and unfortunately because we had to shift the conference from physical platform to the virtual platform, we need to talk to them again and then see how we go ahead. Lastly but not the least, I have to thank my parents. Because of them, I pursued in pediatric orthopedics, and I am here standing in front of you. And lastly, I would like to thank my wife and son for bearing with me. I could not give them attention for last 15-20 days, and hopefully I'll be able to make it in coming days. Thank you very much, POSI and KY, for giving me the opportunity, and we look forward to Bhubaneswar for an exciting meeting. Thank you.
Yeah, thank you. Before I hand over to Dr. Sandeep, I would request Rujuta to say something as a delegate and very senior member of POSI. Rujuta, 1 minute, your expert comment. I know this is extempore, so you are not prepared for this.
That's not a problem, extempore. It's just I hope my audio holds
It's
up
okay.
with me. So yeah, tough times are really tough. I think the ordeal has been equal on every part. POSI is always all committed, and I think delegates definitely attend like minute to minute. I think it's one of the conferences where they're always inside the hall and never really outside. So last minute things, many times we do understand that some people were not really, even some faculty was not really present for their sessions. But then I think we need to realize that COVID has really taken a toll even on them. There are a lot of them who are affected themselves. There are a lot of them who had to fill in for their peers because those are COVID affected. So I think what needs to be really hailed over here is the spirit of everybody, the spirit of POSI, the spirit of Dr. Abhyankar, especially I will say, because I think he, a very worried man, but with a calm demeanor, and yet he has to be a fatherly figure. So I think hats off literally to him, because only one, in Gujarati we say pani pag tale relo ave ene samjhaye. Only the one who is there in the heat of the moment knows how difficult it is. So I think that's huge the effort on their part. And each and every one of us, I think it was good that things got discussed and things got thrashed out. But finally, when it comes to the final reckoning, we all faced it, and we faced it with cheer. We were just as happy to see each other discussing virtually. We even simulated a semi banquet last night on the PD Pods group just to keep that thing going. And the general body is, as always, one of the calmest general bodies in any association. So I think we filled in all the tick boxes. And given the circumstances, whatever we did as a team together, clap and pat on the back for everyone. But yeah, don't forget all the learning lessons organizationally that have happened in this. And they say each difficulty is an opportunity to learn. So let's just get wiser and keep this in our minds forever, that there are some backups to be done. Trying times just teach you and make you tougher.
Thank you, Rujuta. Over to you, Sandeep.
Yeah, thank you, sir. Am I audible? Okay. So at the outset, as POSI secretary, I want to express my gratitude and heartfelt thanks to Kolhapur Orthopaedic Association. It's been a long struggle for 2 years, from Goa to Sayaji to hybrid to virtual. And I have had full faith in Dr. Abhyankar and his team, Deepak, Kotkar, Sase, Kripani. And believe me, we've all been working towards the same objective of having a superb scientific conference. We missed Kolhapur, Tamda Padra, and hospitality. I believe the time will soon come back when all of the people will come back to Kolhapur to enjoy the warm hospitality that Kolhapurkars always have had to offer. We have been at the receiving end of their hospitality for many MOA cons, and I wish all India POSI delegates could have experienced that, but COVID thought otherwise. I would like to assure them that at the last minute, at 1 day notice, OC stepped in, the EC stepped in, just to make sure that the faculty and delegates are receiving a perfect scientific program, which has been seen in the last 1.5 days. It was not meant to hurt, offend, or belittle the capabilities of KOA organization at all. We just I'm sorry if some people have felt offended for that decision. And I must thank my POSI executive and faculty, especially the international faculty, Sanjeev, Kishore, Abhay, and the others from Philadelphia and world over, who contributed, recorded the talk, sent them over, and Ashok Sham for stepping in. It was just that we knew him well and could talk to him 1:1. No offense to Ortho Gurus and Asavari. I believe she would have done a good hybrid meeting as well, but the comfort level was a little different. So thank you, Ashok, Neeraj, Supriya, and the entire OrthoTV team. And I will hand over with this thanks. Finally, 3 cheers to Rajiv Negandhi for stepping up to the occasion. And he may be the youngest secretary, but I hope that he's now got his branding done during this meeting and grows up to be the capable man that he is. So with those last few words, I hand over to Dhiren Bhai for the announcing the winners and the awards.
I think my slides are visible.
Yes, sir.
Yes. So now we go to the most awaited part of the conference. That's the best paper and the posters award. The first of all, I really apologize the inconvenience we have caused to the posters submitter or the presenter. Actually, we were planning to keep an interview where we can ask questions to the posters presenter, but due to change in the program, and we had hardly any time to carry out that session. So on behalf of our executive committee, I assure that we will find out a mechanism where their hard work, both the posters and the video session or the technique session, can be submitted or can kept on the POSI website for a few months so that our members can visit and can watch that. So we will do that. We will find out the mechanism and then we will let you know for that. Coming to the important part, the certificate, again, we will have a mechanism, and like last time, we will send you the e-certificate so that you can print at your end without waiting for the physical certificate. Coming to the best poster award, the best poster award goes to, first of all, let me thank all the judges for the poster and the podium presentation. I'm not going to declare that name, but they have really worked hard in a very short notice to judge the paper. So the best poster award goes to Dr. Chirag Manwani from Mumbai, working with Dr. Vikas Basa. The topic of the paper was low intensity pulse ultrasound for fractured non-union in children. He will receive a certificate and a prize of rupees 3,000. Coming to the podium presentation and the best paper award, the third prize goes to Dr. Shalin Shah from Ahmedabad, and his topic was minimally invasive subscapularis release and conjoint tendon transfer for shoulder imbalance in brachial plexus birth palsy. He will be receiving a certificate and a prize of rupees 2,000. The best paper award goes to Dr. Maulin Shah for his innovative work on the external rotation contracture in brachial plexus birth palsy. Again, he will be receiving a certificate and rupees 5,000. Now, you will have a lot of curiosity about the first prize, and the first prize of year 2022 goes to Dr. Hitesh Shah from Manipal, and the topic of his presentation was the vapor epiphysis, an uncommon presentation in Perthes disease. He will be receiving a certificate and a prize of rupees 10,000. We will be getting the details of your bank account and will transfer the money to your bank account. Coming to the POSICON 2026, usually we decide at the time of GBM, but this time we had virtual GBM. So we carry out voting in a very different way, and we had to spend some time to calculate the votes. And I'm happy to announce that there was a close competition between the first and the second the center, but the maximum votes were for Lucknow. So the POSICON 2026 will be done by Dr. Ajay Singh and his team at Lucknow. So with that, I end my presentation and we continue our scientific program. And for that, I invite Dr. Gupta ji to continue the session. Over to you, Gupta ji. And thank you, everyone.
So good afternoon, everybody. Without wasting time, let's start with the first talk. And instead of Dr. Vrisha Madhuri, Dr. Prasad will be talking about minimally invasive anterior hip approach. Dr. Prasad, please.
Greetings, everybody. My name is Dr. Prasad Gauraneni, and I'm going to discuss a less invasive anterior approach to DDH, to the hip. I'm going to discuss the technique, show some case examples, and discuss the advantages and limitations of this technique. So anterior approach to DDH is pretty standard for all age groups, right? The criticism is it's bigger incision, more dissection, and more blood loss. But theoretically, the AVN rate of anterior approach is supposed to be less than that of medial approach, though that's controversial now. Anterior approach allows you to repair the capsule, do tight capsular repair, while medial approach allows you to do tenodesis of the LT, ligamentum teres. So standard Smith-Peterson approach anteriorly. Most people split the iliac apophysis, detach all the muscles, especially the abductors, all the way down to the hip capsule and posterior to the sciatic notch. This is a standard approach of left hip, Heads to the right, foots to the left. So you're looking from the lateral aspect. Lateral ilium, bone graft harvested already. These are the abductors that are stripped way out, down all the way. And a Pemberton being performed with an osteotome. So that can involve substantial blood loss, pain, probably takes more time. So it's probably 15 years ago, we had a poster in Cosmo on the feasibility of doing Pembertons through a small incision without too much dissection. Few slides from that poster. Small little incision, enough to put the osteotome in, protect the muscles by submuscular tunnels on either side, and then do the osteotomy under fluoroscopic guidance. Here's how the submuscular tunnels are developed. That's the ilium below the ASIS that will be osteotomized. And that's the hip capsule and the femoral head underneath. So you can elevate the muscles off the hip capsule and do a capsulotomy and open reduction. The incision is quite small, but the length of incision is not important. It's what you do inside with the muscles. Again, a heel scar, cosmetic. A more recent case, right hip high dislocation. The incision is big here. We're going to take some pictures here. But the iliac crest was not dissected. ASIS muscle attachment is intact. I believe we took the rectus down, and that's about it. And here's the dislocated head in the pseudoacetabulum. That's the native true acetabulum, which is being cleared. You can see all this without taking the abductors of the iliac crest. Again, same case. Here we're pretty close to get the head back in. The acetabulum is cleared, flaps created, and the capsule is released off from the ilium so that the head can be reduced. And the femoral ring from the shortening is placed for the Pemberton through the same incision. In the case example, a 5-year-old with left hip dysplasia subluxation. Only a Pemberton was done in this case, small incision. Used an allograft. She did well on follow-up. No iliac crest deformity, very little spur formation at the osteotomy site. In the case of left hip dislocation and right hip subluxation, small incision, open reduction, lateral incision femoral shortening, Pemberton being done, iliac, not iliac, the femoral ring that from the shortening is placed in the Pemberton gap. Then we moved to the right side and did a Pemberton without again stripping the abductors. So the limitations, the abductors are very tight that they need to be released off the crest to get your reduction, which happened only once in my probably 25-30 cases that I've done with this approach. Even then, after the abductor release, the hip was tight in that particular case. If you really need to harvest the iliac crest, of course you need to strip some muscles, at least focally in that area. So in summary, open reduction of the hip joint and innominate osteotomies can be performed well without iliac crest stripping. So decreased blood loss with this modification, we should be able to perform bilateral open reductions and bilateral Pemberton osteotomies in the same stage under the same anesthetic. Thank you for listening.
Thank Thank you, Dr. Prasad. That was a wonderful illustration of minimally invasive technique. So we'll have questions and answers at the end. So let's go to the second talk by Dr. Abhay, which is on medial approach to DDH.
Hello, and thank you for giving me the opportunity to talk to you all about medial approach to DDH. I have no conflict of interest to declare. My name is Abhay Khoth, and I work at the Children's Hospital in Melbourne in Australia, famous for the Djokovic saga recently and for a few other things as well. This talk, I would like to acknowledge my mentor and friend, Ian Tarod, who taught me how to do this at the start of my career and has been a major influence in my life and practice as a pediatric orthopedic surgeon. I'd just like you all to take a moment to look at this X-ray and decide which is your preferred option, whether in this situation you would choose option A, B, or C. And then in this situation, a 7-month-old with bilateral involvement, again, which would be your preferred option, A, B, or C. And that will probably reflect what your current preference is. Now, it's not up to me to change it, but I'm just going to give you a perspective that we have in our practice here. Because the goal is essentially one of two. What does the hip need? And alternatively, which operation can I do better? Because the goal in the end is a stable hip with a functional range of motion, which has adequate growth potential, which essentially means the absence of growth disturbance caused by avascular necrosis. And we want that hip to be able to last into adult life and not cause premature arthritis. So the IHDI classification, which Uni, Narayanan, and Kishore have had a big role in developing, is a good way to decide how severe the hip dysplasia is from IHDI 1 to IHDI grade 4, and that will give you as the treating surgeon an idea of the severity of the hip pathology that you're dealing with. The options related to the medial open reduction, I'll share with you things that I've learned. We use a caudal analgesia in addition to a GA. We keep both legs free in the draping. Sometimes we use loops with a headlamp. The child is on a radiolucent table to use image intensifier, and we keep the spica table ready for the end of the procedure. It's very good to have an experienced assistant so that they can retract appropriately, protecting the neurovascular structures without causing any additional iatrogenic injury. And we use vascular tape to isolate and protect the medial circumflex femoral artery. A very useful intraoperative aid is to have one vicryl with an OS4 needle for the tenodesis suture on the ligamentum teres. So it's a short circular needle that has a very short radius of curvature, which is easier to use through the smaller incision. The surgeon stands at the foot end, the incisions in the groin crease, and we identify source before cutting adductor longus to stop you getting lost. The capsular changes, the hourglass constriction is the major intraoperative pathology that needs to be dealt with. And this diagram shows you how the T-shaped incision allows you to open the constriction and allow the femoral head to return to the true acetabulum. And then, as part of this procedure, after dividing the transverse acetabular ligament, we will incise the ligamentum teres not at the femoral head, but at its attachment to the floor of the acetabulum, and then use the ligamentum teres to suture the attachment to the anterior periosteum at the level of the TAL. This then becomes a restraint to stop the hip from dislocating and allows you to have a judicious measure of range of motion. Afterwards, we'll use a hip spiker and then a DB brace. There are 3 outcome papers that I'll just share with you. This is the result paper that discusses the results from our institute and followed up for 9 years, mostly type 1 AVN, a few type 2s, but more importantly, no type 4s. This is a systematic review that looked at all the publications discussing medial open reduction, and they had 2,000 plus that they started out with. And this is a good review paper for those who are interested. But the key messages here are that the AVN rate overall is about 24% for this approach, and that AVN rate increases the longer the follow-up period lasts. So it means that even if you report a lower AVN rate at the start, that may not be the true one. There are lots of other comparisons as well, which if you're interested, you can go and look at. The other paper that I felt was worth repeating was the one from Boston, which looked at age match comparisons between medial versus anterior. And this showed in their length of follow-up, no difference between the 2 groups. So looking at these cases again, for the older child, this would be my go-to option because I have the option of doing pelvic osteotomy and a femoral osteotomy if I need to. And for the second case, I would do a bilateral medial open reduction. So it's okay to not be wedded to one particular technique, but use it to the effect that you need. So to conclude, MOR is effective. It's a technical procedure, but it should be in your toolkit and use it wisely. Thank you for your attention.
Thank you, Dr. Abe, for that wonderful overview on medial open reduction. So the next talk is by me on revision surgery in DDH. Good afternoon, friends. I'll be talking about revision surgery in DDH, tips and tricks. The timeline to presentation as described by Johri et al. Is early, delayed, or late. Please remember the success of surgery, whether in primary or in failure, depends on a concentric reduction, stability provided by an adequate capsulography, and bony stability by an optimally deep acetabulum. And failures are all often attributed to surgical errors. The problem areas include a redislocation or subluxation, a non-concentric lateralized reduction, and a residual dysplasia. It is important to identify potential obstacles, which could be soft tissue or bony. The soft tissue obstacles are mostly because of a suboptimal exposure or an inadequate exposure.
One must appreciate that failure to release the psoas tendon and the transverse acetabular ligament may lead to a lateralized reduction or a subluxation, and in extreme cases, a redislocation. Failure to visualize the acetabulum by mistaking the pseudoacetabulum for a true acetabulum is another problem which needs to be identified and tackled. The classical teaching remains that the ligamentum teres leads you to the true acetabulum. However, one must remember that the ligamentum teres is absent in about 20% of the cases. The tip to finding the acetabulum is that it lies below the anterior inferior iliac spine, to which the straight head of rectus femoris is attached. Hypertrophied ligamentum teres and failure to cut the anteromedial capsule results in a lateralized reduction and a suboptimal reduction. Interposed soft tissue due to inverted limbus and a big pulvinar can also lead to lateralized reduction and medial joint space widening. Excessive femoral anteversion leads to less than optimal reduction, and one should correct it to about 15 to 20 degrees if the femoral anteversion is more than 30 degrees. One should also factor in retroversion, which is caused by a retroverting acetabular osteotomy, usually a Salters, combined with an external rotation femoral osteotomy, as you see in this particular patient. Acetabular dysplasia leading to a redislocation because of a shallow acetabulum. It cannot be overemphasized, and one must take care of a acetabular dysplasia. And usually the acetabular dysplasia is taken care by a acetabuloplasty, usually Degas osteotomy. When and how to intervene in case of a redislocation. If the redislocation or subluxation is detected immediate post-op, as is seen by a widened Shenton line or an obvious dislocation inside the spica, one should consider a limited CT cut in case of doubt. Otherwise, in case it's an obvious dislocation, try a close reduction. If it fails, a repeat open reduction in the same anesthesia and address the capsular laxity and obstacles in the same sitting. Also identify the version problems, and that should be corrected if there are problems with the femoral version. This is one case example where this was a redislocation. On day 2, the spica was removed and a close reduction was done, and patient went in for a good result. This is a child where in the previous surgery, there was a retroversion leading to a posterior dislocation, and a corrective osteotomy in the femur was done. And this is a 3 months follow-up where both the hips are concentrically reduced. In late presentation, again, it is important to identify the factors, and a repeat open reduction is required. And this is, in the world literature, this is about 6% of cases. There could be difficulties because of a misshapen femoral head, a small femoral head, AVN, and if there is a misshapen femoral head, one should consider optimal imaging prior to surgery, either a CT or a MRI to see the sphericity of the head. Fibrosis resulting from the previous surgery is another problem which should be factored in while doing the repeat surgery. What should be the time to repeat surgery? It should be minimum of 6 months prior after the index surgery, and this is to regain the motion and allow maturation of the scar tissue, which will help in easy identification of the tissue planes as well as reduced bleeding. This is one such case example of a late presentation where the dislocation was posterior The acetabular dysplasia was not addressed in this patient, and dislocation was there. So this patient underwent open reduction, a correction of the version of the femur, as well as a acetabuloplasty, and this is a 6 months follow-up with a concentric reduction. Medial joint space widening leads to satisfactory results in only 50% of cases, and poor results are anticipated if there is a widened teardrop, like this particular patient. So to summarize, poor reduction could be due to soft tissue obstacles. One should identify and remove, identify and correct the version problems in the femur. Stable reduction by capsulorrhaphy and acetabular procedures. Redislocation, if detected in the immediate post-op period, consider close reduction, open reduction, and correction of the version of the femur, if it is there. And redislocation, when detected late, one should wait for 6 months for scar tissue to mature. Thank you so much.
So let's go to the next talk, which is on capsular interposition arthroplasty by Dr. Prasad. Dr. Prasad, please.
Greetings, everybody. My name is Dr. Prasad Gauraneni. My topic today is capsular interposition arthroplasty, and a very old technique that has potential. I'm going to discuss the indications, the current technique, and show you my results. Capsular interposition means that you're replacing the acetabular cartilage with hip joint capsule. We don't replace the femoral head cartilage with anything. It's only the acetabular cartilage we can replace. If you look at it, Chiari, shelf, and tectoplasty use new bone to support part of the acetabular capsule, of the hip capsule, to enlarge the acetabulum. So it's not very new. But the Colonna or Codivilla procedure replaced all of the acetabular cartilage with the capsule. Here's a Chiari. The red line represents the capsule that's being supported by the displaced ilium. So he enlarged the acetabulum with the capsular support. Here's a shelf, similar idea. The shelf bone is supporting the capsule to act as increased surface of the acetabular cartilage. So the Colonna or Codivilla procedure. Codivilla described in 1901, Hay Cruz in 26, and Colonna in 32. The Colonna got all the credit. There are several case series with decent results, if you look at it. 0 to 50% AVN rate, but look at it, good function at 20 years in 50 to 70% of the hips. 5% were good at 40 years in a paper that actually condemned this procedure, saying that it should not be done anymore. But 4 out of the 16 patients are still having a good function with normal looking x-rays at 40 years of follow-up. Professor Reinhold Gans modified the technique to make it safer and more reliable, published it in Court 2012. Here's an older Colonna case. Normal head, no acetabulum to reconstruct, but plenty of capsule all around the head that's stretched out. So the capsule is wrapped around the head, acetabulum is reamed, and the head is reduced into the acetabulum. And this hip looks like a near normal hip for both functionally and on radiographs. So what are current indications and prerequisites? The prerequisite is a good femoral head cartilage. You need to have good femoral head cartilage. And then if you don't have any acetabular cartilage to reconstruct, that's when Colonna becomes a good option. Good abductor strength ensures longevity, though Colonna was performed in paralytic hips also. You need to have adequate capsular tissue to interpose and adequate acetabular bone stock. but those can be reconstructed if required. So Professor Ganz's technique, SSD approach, shorten the femur, just like in DDH reduction. Dissect the capsule carefully all around, pretty much, right? And release it from the acetabular side. If you don't have enough acetabular capsule, you can add a dermal graft. Acetabular to fit the head covered with the capsule. So the acetabular should be reamed big enough, but not too big where you go the wall and source seal support. You can add a shelf or reduce the head size to match the head size to the acetabulum. Then reduce the head in, immobilize till the capsule sticks to the acetabular bone, typically 2 to 4 weeks, and then mobilize slowly. Here diagrams from Professor Ganz's paper, capsulotomy around the acetabulum, producing 2 big flaps. Wrap the flaps tightly around the head, remove the acetabular socket with total hip reamers, and stick the capsule-covered head into the acetabulum. Here's a case report of multiple things done. A big head, so the head has to be reduced to fit into the socket. The acetabulum had to be made bigger with the shelf. Femur was shortened and derotated, so relative neck lengthening, trochanteric advancement, colonna. And I think he had a 8-year follow-up the last time he presented it in a meeting. Post-op rehabilitation, you put them in a spica cast. Even adults go into a spica cast. If you're really confident with your technique, you can put them in a brace. External fixator is an option. And you immobilize them for about 4 weeks. If the hip is really stable, you can free them up for flexion after 2 weeks, but overall they'll be immobilized for about 4 weeks. Weight bearing will be based on bone healing for all the osteotomy that will be performed. And abductor strengthening starts after the great trochanter heals. For the advantages of this procedure, it's lower risk of AVN now with the SSD approach. Restores all elements of hip function. The hip pretty much looks and works normal. The results are durable, and it's easy to convert to a total hip if required at some point. Personally, I did this surgery in about 4 cases. All hips had multiple surgeries before. None were virgin, like all were operated on before. 2 were somewhat simpler in reconstruction, not a whole lot to be done. One of them is doing really well. I see her often on follow-up. Another one developed a deep infection. Mumbai. 2 were done at Amara. Both were very complex. One had 14 previous surgeries. Both had minimal bone stock really to do an operation. One is doing well, a medical student. But the second one is not quite well. Though clinically she's doing well, the results are not as good. I'll show you the x-rays. Here's the first one doing really well. Hip looks almost normal. Here's the second one, example. Barely any head, neck, trochanter high. Was surprised that we were able to even reconstruct and do a colonna. But with all this dissection and all this operation, she ended up getting AVN, but clinically doing well even now. It's only early, 2 or 3 years. I hope that she'll get at least 5 or 10 years with this hip. Subcolonna, or the capsular interposition arthroplasty, should be called after Cody Villa, has the potential for lasting good outcomes. 70 to 80% at 20 years, better than any total hip in this age group. Thanks for listening.
Thank you, Dr. Prasad, for that wonderful talk on capsular interposition arthroplasty. So Dr. Mangal Prihar will not be presenting. So we have the last talk, which is the total hip arthroplasty in skeletally immature.
Hello, my name is Callum McBride. I'm a consultant hip surgeon, specialised in surgery in the young adults and adolescents. I work at the Royal Orthopaedic Hospital in Birmingham, United Kingdom. I'd like to thank the organising committee of POSICON for kindly inviting me to talk to you today, and I'm going to be talking about hip arthroplasty in adolescents with open triradiate cartilage. So there are a number of things that we need to think about when considering whether to do a joint replacement in childhood. And is there an age that a child is ever too young to consider a joint replacement? And if so, what age is that? What is the outcome of arthroplasty in skeletally immature patients or indeed adolescents? And what implications are there on arthroplasty in patients who've had prior surgery to the hip for childhood hip conditions? And how long and how well is any joint replacement going to last? So we know that the triradiate and the proximal femoral physis close around puberty, slightly earlier for girls at around the age of 12 and for boys around the age of 14, although there is considerable variation to this. And does this really make any difference in the outcome of joint replacement? Well, there are certain situations in which it really makes no difference at all. And I'm just going to mention oncological reasons in which there would need to be a resection and a arthroplasty procedure performed, often a proximal femoral replacement, an EPR type prosthesis. And clearly this can be done in children of ages 8, etc., and is done routinely where I work and in other oncological departments across the world. But the focus of my talk today is about other situations, something like this, a patient here with bilateral avascular necrosis. And what, of course, is most important here is not the X-ray, but it's about the severity of the patient's symptoms and their quality of life. And also, what other options are there? Is there any surgical option here that is going to be a benefit other than an arthroplasty? So this is the question, is what hips can we operate on to do hip preservation procedures and what cannot be saved? And the ones that tend to, in our experience and in the literature, that can't be saved are those severe AVNs, most frequently due to Perthes, but also following chemotherapy, steroid use, SUFIs, post-surgical SUFIs, post-traumatic and post-infection, and they consist of the majority of patients that we would see with really dreadful hips. And there is also, more rarely, epiphyseal dysplasias. So what should we be considering as to whether and if a patient should have a hip replacement in this young cohort? So here's an X-ray of a patient who's had a failed fixation for a severe SUFI in which the total epiphysis has died away. Well, the question is this patient in pain? Or is the functional effects having a significant impact on their quality of life? And these can be really devastating. It can have an impact on their emotional, physical, educational, social development. And all of these need to be understood and considered in consultation with both the patient and their parents. Some patients may have cerebral palsy or other syndromes which may mean that they are non-walkers and spend most of their time in wheelchair or even in bed, but they may still be in agony and they may still benefit from an arthroplasty. So it may not be realistic to get them walking, but you may be able to make their quality of life improved. Consideration for particularly the syndromic patients is how long they may live. It may be considered arthroplasty is a good palliative operation that will provide them with good nursing care for the duration that they live. But for those patients, the life expectancy is going to be normal, and so we do need to consider the impact of multiple revisions on them. Leg length discrepancy needs to be assessed, as it is only really possible to correct 3 centimetres or so at the hip. The patients may be at increased risk of complications, particularly if they've had infection around any of their previous surgeries, and this needs to be considered and ruled out. And then careful consideration needs to be thought about who's going to be doing any joint replacement. When and what age should it be done? Which surgeon who should do it? Should it be a surgeon who does lots of joint replacements in this young cohort? Is it going to be done at the adult arthroplasty centre or the paediatric orthopaedic centre? And what implants are going to be needed and what implants are best? So I'll just show you some examples. Here is a patient with syndrome and spasticity with a dislocated and very painful hip, trying to walk but losing her ability to walk. Do a hip replacement and significant pain improvement. This patient now, some 6 years later, having had spinal surgery, but remains very pleased with her well-functioning hip replacement. Here's this young lad, otherwise completely normal, but developed a vascular necrosis of the hip, had more procedures, but unfortunately there was no option other than to do a total hip replacement, and he's done extremely well. Patient here with a syndrome had previous surgery and a paediatric orthopaedic surgeon, and we had a custom tiny little hip replacement made individualized for the patient. And this is her 6 years later, and she remains walking and delighted with a hip replacement, having been in agony prior to this. Another patient with a very abnormal subluxed hip, but this is in a non-walker, and they were having great difficulties with the behaviour of the child, and a confirmatory injection into the hip changed the behaviour of the child. And in those days we were able to do a resurfacing with the large head, which provided great stability for the hip. And here they are again some 6-7 years later with really good outcome. So that's my experience, and it's matched in what's in the literature. So here's 3 papers over the last 3 or 4 years. Probably many of you will be aware of the top left one in the Journal of Pediatric Orthopaedic. I'll just summarise really what those show in my own experience. This shows significant improvement in the quality of life scores and hip scores of these group of patients. There is higher risk of complications, vascular injury and dislocation in this group, but not only do you improve the quality of life of the child, you improve the quality of life of those around them. There's no evidence of increased risk of implant loosening, even in those with surgery performed before the triradiate closes, and albeit early outcomes, they are good. There's very limited, in fact, almost no published data on the long-term outcomes. And the default, if it all goes wrong, is a proximal femoral resection, which is my preferred treatment for this group, rather than nodal stone. So the things I think you need to consider as a paediatric orthopaedic surgeon is, if you're going to be doing any form of surgery, think about the impact of that on the tissue and limit it. Make sure that it's going to be effective, obviously, and always bear in mind that this child may still require hip replacement sooner or later in their life. Consider whether, in fact, not doing that and the patient going straight forward to an arthroplasty procedure as a single procedure might be better. And to assist you in that decision making, discuss with a high volume hip replacement surgeon at an early stage. Remember that 3 centimetres is about all that we can correct at the hip, and so you may wish to plan and consider epiphysiodesis if it's going to be a leg length discrepancy of greater than that. And arthroplasty is almost always better than resection or fusion for the majority, regardless of age. Thank you very much for your time.
Thank you for that elaborate talk. So now the session is open for discussion. Any questions from the audience?
Yeah, PN, can I ask Dr. Abhay one question?
Yeah, sure.
Yeah, Dr. Abhay Thomas here from Vellore. Abhay Jr., Gaukamli, who trained with you, and Dr. Ian, we've started doing this medial open after he came back, and we done about a dozen of them, but we found it difficult to do the high riding ones, the IHJ, the 4 types, the high riding ones. Any tips on that, or is that, or should we not attempt the high riding ones, even if it's 8 to 10 month one?
Absolutely, you're right. Sometimes the medial approach only gets you a good view of the TAL and the floor of the acetabulum, but not where the femoral head's actually sitting. And in those cases, I would be very, very clear that you have to go to where the problem is. And also that in the high riding ones, just the approach is not a gateway to reduction. You'll need detention. The hip might need to do a femoral shortening. So there's a whole bunch of other factors that go into your decision-making process. And I suppose the key lesson that I've learned over the years is you've got to do what the hip needs rather than what we feel comfortable doing. So follow your judgment there, and you'll be making the right choices. The easiest ones are in the younger ones, the bilateral ones, where it's such a slick and quick procedure, even to do bilaterals with minimal blood loss, that you don't need to stage it. That's where I find it works best.
No, the high riding arthrogrypotics, which are 8 to 10 month old. Those are the ones I'm talking about.
So in those situations, it'll all depend on the amount of the capsular release that you need to do. And that limb of the capsulotomy, which goes underneath the medial circumflex, that's got to be the most critical one. Once you've opened that, then the other limb of the T, I have a retractor that goes under the neurovascular bundle over the femoral head, and that then allows you to follow the capsular incision till you get past the femoral head, and that should then give you enough of a window to bring the femoral head down. If it's too tight, or you've got to get it into a really awkward position to hold it in, I'll hold it there and open the femur and take the tension off by with a femoral osteotomy, rather than try and force the reduction through just one medial window.
Dr. Abhay, can I ask you something?
Sure.
Dr. Abhay, you said that you sort of suture the ligamentum teres tightly to the inferior medial aspect. So does that in future, does that limit the abduction of the hip in any way?
Not that we've seen. Ian was always very particular in saying that this was to help improve the stability, because most of the time the failure of reduction is a subluxation that occurs posteriorly. And if you remember how people used to insist on having a big mold in the spica over the GT to try and keep pushing the femur up. And it caused a whole bunch of problems. Either that, or you have to abduct it a huge amount to try and keep it in the acetabulum. So essentially, the tenodesis only helps to overcome these two problems. In the end, the hip capsule reconstitutes itself, and there is so much growth and change that is yet to occur after the hip has been reduced that all those factors have a much bigger role to play in function rather than the tenodesis itself.
So a question to Dr. Prasad. Dr. Prasad, are you there?
I think he's not there,
Okay. So any other question?
Sir, I have a question to Dr. McBride regarding the role of pelvic support osteotomies in these cases. We all know that that is a good and viable option in these adolescent patients who have this kind of hips. So would
Hello.
I do not think he is.
I don't think so.
Yeah.
He's not joined. So there are 2 or 3 questions in the chat box. One is, how do you evaluate the version intraoperatively on table? The best way is that you pass a wire in the center of the hip, as you do in a dynamic hip screw. And you take a Dunn's view on table, and then you calculate the angle between the patella forwards position and that wire. Or you internally rotate the limb, keep the wire parallel to the floor, and that will give you the amount of version. The second question in the chat box is again to me is how to reduce a misshapen femoral head in DDH. So it's a very, very difficult situation if the femoral head is misshapen and if it is if there is a coxa magna along with. So if it is not possible to reduce fully, then you reduce it with whatever how much is possible, and consider a salvage procedure for the acetabulum rather than going in for a regular osteotomy like a Degas or a Salters. So you consider a salvage like a shell or a Chiari. So there is another question. What is the consensus about PSO, pelvic support osteotomy versus total hip in adolescents? So do we have, yeah, Dr. Abhay?
I'm not a hip surgeon, either am I a limb recon surgeon, but for what it's worth, in our unit, we are doing fewer and fewer PSOs and more THRs. So our limb recon colleagues feel that the functional improvement with total hip arthroplasty is miles ahead of that offered by a PSO. So when they counsel that particular group of young patients, they all tend to go for a total hip. A similar change has occurred in the choice between arthrodesis and arthroplasty. About 15 years ago, we were doing more arthrodesis. I've not seen us do one in the last 5 years, but we've done many more total hip replacements. So if you look at quality of life and functional improvements, total hip arthroplasty wins against a PSO, at least in our practice. This is in a place where this kind of infrastructure is available. If it is not, then of course you have to go with what works in your setup.
Yeah, perhaps I think what is important is what is the social and socioeconomic status and whether the person is able to afford repeated replacements. Yes, Dr. Tarun.
Yeah. So it's a practice question that as more and more pediatric hip conditions are going to require this reconstruction and arthroplasty, should we train ourselves into doing a young arthroplasty for a young patient, or should we hand it over to an adult hip reconstruction surgeon? We've already lost battle with spine. Most of the spinal deformities are done by spine surgeons. This is another big chunk of cases which we are going to hand over to adult arthroplasty surgeons. So should we take it up and do it ourselves? Are we better at it, or should we leave it to the adult hip guys?
So if I could just look at what's happening here, we all know wherever there is a joint registry that the outcomes are better with greater volume. So if you just think on what happens in normal practice, those who are doing more arthroplasties will always get a better outcome than those who are doing fewer. So that argument then goes in favor of the arthroplasty surgeons doing it. However, I still feel it's much better done as a team approach. So you can, as the pediatric orthopod, have a much clearer understanding about the child and the family and the pathology and all the other things that the arthroplasty surgeon wouldn't have a clue about. And so the best outcome is probably with a team approach rather than a handoff approach. And that's what we do here.
I'm sure there must be many more questions because pediatric hip is a very, very interesting topic. But
I know, I feel very
time,
privileged to be part of this. I've learned so much.
I think we need to end the session here. So I thank all the speakers for a wonderful session. Thank you so much.
That's great. Thank you very much. I shall go back and watch the Ashes now.
Yeah.
Thank you very much, all the faculty, all the presenter, and Dr. Gupta ji for excellent moderating the session. Now we move on to the last session of the POSICON. That's the interesting case discussion on trauma by Dr. Taral and Dr. Tushar. Over to you, Taral.
Yeah, thanks, Dhiren bhai. Yeah, it's always good to score the highest in the last match. The slog overs are here, and I would invite Tushar to share his screen and be the opening batsman and start the match. Tushar, all over to you. Please make it full screen. Please
yeah. Start. So guys, am I seen, visible and audible, right?
Yes.
Yeah, great. So it's always good to conclude with trauma in this pediatric meeting, as the bulk of regular orthopedic surgeons who would be really very interested. And if you see any meeting on Monteggia fracture, it always has a session on missed Monteggia. So in spite of learning so much on Monteggia, it continues to remain an enigma and a mystery. So we decided to collect a bouquet of Monteggia fractures and present to you all. And I thank all the panelists to be here and help us out with the case discussion. So this is the first story. So now here we had a patient who presented to us. She's a 4-year-old girl, and this was her presentation. This was roughly about 4 days from trauma. So any opinion from the house, from the panelists? How would they receive this?
Samir Desai, yeah. Samir, you please unmute and say, oh, this is the patient.
So Tushar, as you mentioned, missed Monteggia is very common. And so this is in this child, there is a radius and an ulnar fracture. And if you see the radius, it is subluxated laterally. And so this child, what we need to do is we want to reduce the radial head and get the length of the ulna. There's a bowing in the ulna. So we have to correct the bowing in the ulna so that the radial head will sit.
So an interesting question here is, would you care to sort of classify it, the Bardo's classification? What do you think it is? Anyone from the panelist? So it's both bones forearm and the radial head is lateral. So do you think it
falls? I think it is a combination of a type 3 and a type 4 Monteggia.
Yeah.
So it's a lateral dislocation with a both bone forearm fracture. So fracture of the radius also. So it's almost like a combination of a type 3 and a type 4.
So we went ahead and we reduced the deformity of the ulna, and we got this kind of reduction intraoperatively. So since the kid is very small, would anybody want to conserve it, like just treat it in a cast at this stage? So this is, any of the panelists would care to opine?
Yeah, let's ask Mandar again. Mandar, this patient, yeah. So it's type 4. It's known that just a conservative treatment doesn't work that well. Is conservative treatment sufficient for this, or would you like to do something else?
So in this case, I would definitely like to nail both bones, just so that I'll be sure that the reduction is maintained.
So
Tushar, what I would prefer in this case is to put a rush rod from the polychronon and just nail the ulna. The radius will sit back automatically.
We have two opinions here. Let's see what happened. So I intuitively nailed the radius. You know, at that point of time, I actually thought, let me just convert a Monteggia 4 into a Monteggia 3. Okay. And we nailed the radius. but obviously we have to nail the ulna. So routinely I nail the ulna proximally, but from the proximal and lateral aspect of the ulna. So would the panelist opine as to what would their approach have been if they had to nail this ulna? Would they have gone from the proximal to distal or from distal to proximal?
I think Ranjit is here. Ranjit, you want to unmute and say? Yes. Ranjit Deshmukh.
So
we are not able to hear him.
So is Ranjit speaking?
No, we can't hear him. He did give his answer in the chat box.
He is saying he is unmutable.
Unmutable. Okay. Okay. So anyway, Sandeep, you can answer on his behalf from Pune. You know, how would you nail the ulna? That's the question Tushar is asking. Sandeep, you want to answer that?
And normally I would go from the olecranon side, not from distal. That is my standard approach, because I find that the distal ulna has got more cortical bone and the canal is a little far away. So sometimes it's very difficult to pass that nail. Though for Siam purposes, it is easy. But entry into the canal is much more direct if I go from olecranon, a centimeter away from the apophysis.
So Sandeep, the question here is that the radial head is already subluxating laterally all the while. So would that hamper the nailing, the positioning or anything?
That shouldn't hamper the ulna nailing, but the radial head needs to be made stable.
Okay. So what I gathered from what Sandeep is saying is we can go from proximal to distal, and once the ulna is nailed, the radial head would become stable. So anyway, we managed to nail from distal to proximal. This patient then had implant removal and had had a good outcome. So I need everybody to focus on this, and probably many of us don't know that there was a publication from Bhandari and Jindal in 1996 and in none other than JBJS, where they have subclassified the Bardo type 4 into 4 types. And they had a patient in which there was a posterior radial head dislocation with a posterior angulation of the ulna fracture. And they said that there is a need for classification of this Bardo type 4 into these 3 subtypes which they have given. So this is a very interesting take, and surprisingly, it has never been sort of quoted much. And the first time we actually found was in 2011 article by a Greek author, where he was discussing a Monteja type 4 equivalent. So that's the time this article got discussed. This is the original article from Bardo, where he talks about numerous equivalents and his primary classification. This all was discussed yesterday also in the session of Monteja. However, we need to know that there have been numerous attempts to sort of classify Monteja and to put all the Monteja equivalents together. So I found this interesting publication bought by Dr. Chinoy from Hinduja Hospital, where they had a lateral condyle fracture with posterior elbow dislocation. So they have called it like the type 3 Monteja equivalent. This case of ours is soon going to be published in IJPO as a Monteja intermediate type injury between type 3 and type 4. We go to the next one. So this is how we received the patient. It was very ghastly. And, I do a regular OPD. It's not like a big trauma OPD. So it was pretty ghastly to receive the kid like that in my clinic. And these were the X-rays. So from this available X-ray, any of the panelists would like to opine what is happening, what is happening here, what kind of fracture is it? Since it's in the Monteja session, it's obviously Monteja, but is it any variant that they think it is?
We'll ask Dr. Maulin Shah. Maulin, please unmute yourself and say this is a compound Monteja, short oblique.
Yeah, so this is, thanks Tarul for asking. So this is a variant of Monteja where the radial neck is fractured and ulna is also fractured. Coincidentally, we have published this variant of Monteja in Journal of Orthopaedic Case Report. Here, you have to reduce it, and I think you have to nail ulna as well as you might require an open reduction for radial neck. So this is a difficult situation. But you can get an anatomic reduction. Yeah.
I think individually, all the panelists, if they will let me know what would be their choice of hardware here.
So let's start from Mandar Agashe.
Length unstable.
So this is a very length, as you said, it's a spiral, almost like a spiral fracture. I'll do if there's a compound wound, I'll do a debridement, and since it's open, I'll do a radical debridement and fix it with a plate, because I want a very, very stable reduction for the ulna. For the radius, I'll probably do an intrafocal reduction and then fix it with a nail.
Okay, quickly going to Samir Desai, anything different or same?
It's been already discussed that it's an oblique fracture of the ulna, so I would like to plate the ulna, and I'm not sure whether I'll be able to get the radius.
I think we lost his sound. Tushar, yeah, go ahead.
So I plated the ulna as discussed, but I had opened up the whole thing, anticipating that I may not be able to reduce the proximal radius neck fracture, and we actually nailed to stabilize the radius. This is how it looked. Everything was stable, and this is how eventually it is now appearing. So I would like to bring to attention to everybody. This is a very recent article of Monteja equivalent lesion. So there is this terminology called PMEL, which is pediatric Monteja equivalent lesion, and they put all the other sort of equivalent lesions together and then brought about their own classification. But not delving into these details, I would like to summarize is that there is an ulna injury for it to be called as a Monteja equivalent, and there is a proximal radius or a radial neck fracture. And then depending upon whether the radial head is inside or the radius is or radial head is dislocated, they would be further classified. And our patient, which we just discussed, falls in this 3A, which happens to be the most common pediatric Monteja equivalent lesion.
So Tushar, your radial head reduced when you plated the ulna, or it was still displaced?
No, it didn't. No, so it didn't reduce actually. Till I could achieve the reduction and plating, I was not even able to get the length. So because it was not reducing and I had required to hold the radius shaft in alignment with the radial head, that's why I used the nail.
Right.
So it would not have.
One question I want to ask Tushar. Yeah, there was a small sort of a 1 centimeter wound, an oblique fracture. Your total area of debridement seems to be quite vast. So was there a lot of internal injury in these patients?
No, so it was not.
What is the?
You know what, Dharal, actually, I thought I may have to do an open reduction of the radius. So I took an incision like a missed Monteja. Means I took a whole incision like a Boyd's, extended Boyd's approach, and fixed the ulna and also opened up the proximal radius. So I'll summarize here is that we pay attention to radial head, we pay attention to radial neck and proximal radius. As the current pediatric Monteja equivalent lesions say that all proximal radius fractures are also a part of pediatric Monteja equivalent. We should pay a lot of attention to the direction of displacement, to the violence and the in the trauma and the fracture geometry to decide what hardware we want to use. And some of the Monteja equivalents have included distal humerus, lateral condyle and distal radius fractures also. So let's pay attention to these parts. So I'll now unshare my screen and now Taral will take over.
Yeah, absolutely. So we had two interesting acute Montejas, the two variants. And normally it's said that normal patients don't come to Tushar. Always he'll have such odd variants, which he treats very well. So in the first case, we had type 3 to 4 Monteja, and very rightly he converted 4 into 3 by first nailing the radius, fixing the radius. So you reduce the complexities and then you fix ulna, and lastly he could get the radial reduction. The next one, compound Monteja. Please remember it's a severe soft tissue injury. So just a nail or conservative treatment will not help here. You need a more rigid implant because the amount of soft tissue injury is much higher. There are also papers about compartment syndromes in Monteja, and taking wider incision, exposing and doing a fasciotomy in these cases also makes sense. So some uncommon injuries, but a common sense approach by Tushar, which has prevailed here. So now going to cases which came to me little delayed, and let's see what the panel has to say. So this is the third story of a 9-year-old child who had a nerve injury with Montegia. So this patient presented with injury to the elbow and forearm with a swelling, and he went to an orthopedic surgeon where attempt to reduction was done with a slab. So this was the initial sort of a fracture. And I'm coming back to Mandar again. Mandar, with this kind of injury, can you just describe what is the injury, what are the components, and what is the type or the classification you are thinking of, and how will you manage this?
Yeah, so this is almost like an olecranon fracture with a radial head dislocation. Though here there is a slightly different thing, because on the lateral view you can see that there is an anterior dislocation of the radial head, while on the AP view you can see that it's subluxed laterally also.
Right.
A combination of an olecranon fracture with a radial head dislocation is something known as a Hume's fracture. So this is one of them probably. Though a lateral dislocation, always we have to think of the posterior interosseous nerve here.
Right. So how will you manage this?
So again, in most of the Montegia cases which we see, the threshold for fixation is very low. So in this case, I'll probably nail the ulna, reduce it and nail the ulna. Though again, I'll see the preoperative neurovascular status, neurological status.
So that's the preoperative neurovascular status. And this child is not able to extend the thumb and the fingers at MP joint. So I want to ask Anirban. Anirban is here. Is POSI's beloved hand surgeon. So you have a combination Anirban acute injury, this Hume's variety of Montegia, olecranon, and radial head dislocation with your radial nerve pulse or a posterior interosseous nerve pulse. So what should we do? Should we explore or treat this in a closed manner? Anirban, are you there? And if Anirban is not there, I would request Binoti. Binoti, just unmute yourself and tell us how do we manage this. Dr. Binoti Shet. And okay, if none of them is unmuted, Venkat, you want to have a venture into telling us?
Yeah,
Venkat Das.
Taral,
yes.
So I think I agree with Mandar. I mean, even if there is a nerve injury, we think in terms of neuropraxia only initially. We would not do anything for the nerve injury differently. We'll just manage the fracture and then observe what happens to the nerve injury.
Okay, so what happened is, these are the choices, and you said you will do close reduction and first, and what about the olecranon? Mandar said that needs to be fixed. He has a lesser threshold for
yes.
Fixing it. Would you fix that as well?
He'll do a tense nailing. I'll fix it with KYS. Because it's at the level of the olecranon, I prefer to fix it with KYS, reduce it and fix it.
So Ranjit is also saying close reduction and observe. From the delegates, you can type in the chat box and tell us what would be your choice of procedure. Would you prefer a close approach or an open approach? Sandeep Vaidya, open exploration of the nerve. Sandeep, please unmute yourself, So you have, Venkat from the Mecca of Trauma, he's saying close reduction. Sandeep, you are in a small nursing home and you want to do open reduction of this fracture and exploration. What are your reasons for doing that? Sandeep, please unmute yourself.
The reason why I would go for open exploration is that because there are series and case reports which document entrapment of the posterior interosseous nerve in association with these type of injuries. So I might give one gentle attempt at close reduction, but if that fails, then I would not really try to push the radial head in. Then I know that there is a soft tissue interposition, in which case I would go ahead with open exploration.
So you know what? I had 2 encounters with this patient. The first encounter with this patient was on WhatsApp, Tusha. So I was sent these X-rays and this picture, and I said I will do a close reduction. Jayant, Raman, everyone is saying close reduction of radial head with ulna fixation with a wire, and I advise the same thing. Under anesthesia, the reduction did not come. Then they went to Neeraj Bijlani, who is hosting this show. Neeraj knows about this patient. So, he saw this patient, and then again, close reduction was not successful. And when they came to me now at this stage, this was almost 2 weeks down the line, where the child still has neuropraxia. 2 attempts at close reduction were not successful. So, I had no option. I said, this is something fishy. Let me see what's happening and treat this. And I had sufficient time to go down to the literature. Just 2 papers on posterior interosseous nerve entrapment after Monteggia fracture dislocation. And in these papers, they said 4 out of 5 patients, they found the PIN to be entrapped. So out of 5 patients, only in 1 they were able to get a close reduction successfully, but in 4 out of 5, the interosseous nerve was entrapped and they actually had to open. So this is what we saw when we opened. When we opened, we saw that the posterior interosseous nerve was actually entrapped between the radial head and the capitulum. And that was acting as the irreducibility factor for this fracture. And you can see that there is, because of the attempts at reduction, there is little bruising of the posterior interosseous nerve, maybe because of injury, maybe because of attempt at reduction. And you can see very carefully, we separated the nerve. And as soon as we took out the nerve away, the reduction was a cakewalk. We could easily get a reduction. And what we did, we didn't end at that. There was a thick flap of the annular ligament, which we could see in this patient. So again, question coming back to you, Sandeep. Open reduction has been done. The nerve has been taken away. And you see this thick flap of soft tissue. A part of it is torn annular ligament. What would be your choice here? Are you going to leave it as that, or you would tend to repair that in some way? And if you repair, what is the choice of procedure? How do you do it?
In most cases, it is the fibrotic remnant of the annular ligament. But in your case, the case is quite fresh. So in that case, I would like to, whatever flaps of the annular ligament you get, try to encircle it along the circumferentially around the radial neck and suture it with a vicryl suture. That is what I would attempt to do.
So I've seen our adult upper limb colleagues using a suture anchor, actually using a small suture anchor, anchoring it to ulna and then taking sutures through it and sewing this. But we didn't have it ready, and neither am I am trained to use a suture anchor very skillfully. So this is one of the things we want to get trained into, using suture anchors. And I'm sure at Orissa's conference we'll have a workshop on how to use suture anchors for a pediatric orthopedic surgeon. But however, I could suture it back, and then we fixed the olecranon with a K-wire in a closed manner, and put the plaster with elbow in flexion so that the radial head remained reduced well. I checked the reduction of the radial head in flexion, in extension, in pronation, supination. It was quite stable now. And this is how we sutured the annular ligament, with a 1 number vicryl. And this patient, over a period of time, we removed the slab and wires, and his radial nerve recovered after a month. So, we were lucky there. The 2 strong messages for this patient is, from this patient, what we learn is that if you have an irreducible radial head dislocation in a Monteggia, think that something is obstructing. If you have irreducible radial head dislocation, irreducible Monteggia with a posterior interosseous nerve palsy, always think that the nerve may be entrapped. And be careful, don't be very harsh with reduction, be gentle with reduction, and be open to the idea of opening the radial head and doing an open reduction after separating the nerve. So that's how this patient went on to coming to the next patient here. Again, something where things didn't go as expected. So it's a slippery customer, and this patient looking very simple, ulnar fracture with a radial head dislocation, a simple Monteggia. And I want to ask the organizing secretary, Rajiv Negandhi, please unmute yourself, because I'm sure your voice would have opened up now. You're free of all the tensions, apart from giving refund to the delegates. So how would you manage? You have to start your practice now.
Yeah.
and this patient comes to you.
So I think there is fracture of ulna and radial head is dislocated. I'll just put a nail to maintain the length of the ulna, and hopefully the radial head should come back.
Okay, Viraj, how would you manage this in Nagpur? The common man, never underestimate the power of a common pediatric orthopedic patient.
Yeah, Taral, I think is a very standard practice. So you have to reduce the radial head and then maintain the length of the ulna by just putting a K-wire and in good plaster. The quality of good plaster is very important, so that
Yes.
Yeah, that is very important.
Okay, so from chat box, this is to all the delegates. Anyone feels this is not a run-of-a-mill routine Montegia, which you can just treat with either close reduction plus minus spinning. Yeah, please put in the chat box, and I'm waiting for your comments. Anything additional? Dr. Sudhir Mahapatra. Yeah, how would you manage? In Orissa, how do you manage this, Sudhir? We are eager to come to Orissa for the next year's meeting. So unmute yourself, and yeah, Sandeep Vaidya says it looks standard to me. So it is standard. It's pretty standard, except for the fact that it went to a pediatric, to a general orthopedic surgeon, reduced under anesthesia, and he called him after 2 weeks for a check X-ray, and he was horrified to find these X-ray. There was a redislocation. Either it was dislocated to start with, or there was a redislocation. What do we do? Yes. Anybody? Yeah.
Sir, Sir Sudhir speaking, sir.
Yeah, please.
Sir, there seems to be a communication at the fracture site in this patient. So, so maybe at the initial period when if it is not possible to reduce the head with close reduction, I would like to open and do some kind of distraction osteotomy at the fracture, and some kind of distraction plating. Not osteotomy, actually distraction plating. I feel there is some kind of what is needed is distraction and flexion of the ulna.
Jayant is very tense. Yeah, please. Yeah. Next one. Please say.
I'm just squinting. So the fracture looks reduced. So if the fracture had displaced, then I would be concerned that there was something to do with the ulna. But the fracture looks reduced and the radius is still out. So logically, I think there is something interfering with the reduction of the radial head. There might be something entrapped in the radiocapitellar joint, and that might need to be opened and released.
Well, one point is regarding the position of immobilization. It should be in supination and hyperflexion. So here it seems to be neutral and less than 90-degree flexion. So
absolutely, it's a very valid, important point that it should be in hyperflexion. And when you are not in hyperflexion, the biceps tendon can sort of yank it out and redislocate. So Sandeep, now we are 2 weeks, from the injury. 2 weeks from the injury. I want to invite Atul Bhaskar. Atul Bhaskar is master of Montegia, has published maximum on Montegia from POSI. Atul, what would be your approach? Please unmute yourself. So a lot of opinions from the audience, bent nail to be used, ulna to be nailed. There may be entrapment. Atul, is he around, or he's busy with his drink? Maybe one of the two. So
in the Montegia, it is basically two columns. Or out of them, if even one is remain collapsed, system is going to fail. So you have to tackle whether there is some interposition, and you have to reduce the head, and you have to at least stabilize the ulna by putting at least the K-wire. that is very important. So otherwise, if that fails, again the radial is going to dislocate. So I think
now,
after 15 days, still you can manage by close method. Still you can manage.
So they went to somebody, tried close reduction again. I really didn't know what happened, but when I saw the child, it was 1 month from the injury. And this is the X-ray now. Viraj, 1 month from the injury, you have the radial head dislocated, you have ulna fracture which is healed up. How are you going to manage now? 1 month from the injury, how are you going to manage? What's your option?
I think 1 month for this small child, it is not going to come with just simply by close method. I think you
Yes.
need to go ahead for the open reduction of the radial head, and then you had, because if you see there is some, I don't know whether this is just a part of the radial head or this is something some entire fragment or
So,
the,
so what you see as calcification is the calcification in the annular ligament. It's a known phenomenon.
Yeah.
What you see here, I'll just annotate it and show it for people. So this calcification is what Viraj is talking about, and that is the calcified annular ligament. Really doesn't matter much. Hitesh Shah, Dr. Hitesh Shah from Manimal, just unmute yourself. 1 month old Montegia now with a radial head dislocation. What would be your choice of procedure? Hitesh, you want to unmute? And if Hitesh is not able to unmute, yeah, we can ask. Yeah, please.
I think, yeah. Can I answer?
Yeah,
Dr.
please answer.
Ranjit.
Yes.
So I
Ranjit, please
think
answer.
I think you would need to treat it like an untreated Montegia. You will require an osteotomy and angulate it at the ulna, and you may require to open reduce the radial head also.
So how many of you feel that ulnar osteotomy itself will be good enough? How many of you feel that radial head opening may be required? So again, type in the chat box if you feel ulnar osteotomy itself is more likely to be sufficient. Like Dimutu is saying lengthening ulnar osteotomy. Vinod Krishnan, distraction osteotomy of the ulnar joint. So most of them are saying that it is required. Vidyasagar feels that both are required. Vidyasagar, please unmute yourself and tell us why do you feel that both are required in this patient? Just not ulnar osteotomy itself may not be sufficient.
Yes, sir. Because previously even the angulation, everything was corrected. Despite that, the radial head failed to reduce.
Right.
Position. We don't think that again doing the ulnar osteotomy would reduce it back again.
Right. So what we did was a step-by-step approach. In this position, no one knows, what is the real problem. So what we did was an ulnar osteotomy, applied a fixator, and gradually distracted the ulna on table, but radial head would not reduce. So we had to open the radial head here, and from this approach, and what it again showed is a interposition of the annular ligament. Annular ligament was interposed. The whole question was, how are we going to reconstruct the annular ligament? And for reconstructing the annular ligament, again going back to some recent papers where they said in a semi-acute situation, when you find an annular ligament or a remnant of annular ligament, what you do is make a small hole through the annular ligament, and then put your radial head through that hole, as you would put a head of a child through a sweater. The similar way, put the head through a slit in the annular ligament, and that sort of is a repair or a reconstruction of annular ligament, which is advised in semi-acute cases. So this is what we did. You can see the rent which we made in the annular ligament, and through this rent, you put a disc forceps, dilate it, and deliver the radial head through it. And once you deliver the radial head, you notice that you have, say now, radial head here, and the annular ligament all around, in which we made a slit and we delivered the radial head through it. And a simple procedure like that works well in this situation where you have sizable chunk of the annular ligament. So you can see now it reduced very well. The ulna was maintained in the external fixator, and this healed very well because this was a semi-acute situation. This osteotomy healed in around 6 weeks time. We removed the fixator by 6 weeks and then mobilized this patient, and she did very well. So we had 4 cases here of Montegia, which were a little different, a little mysterious stories, little apart from what a routine Montegia would be. So thank you very much for listening to Tushar and me. If there are any comments on these 4 cases or in general on Montegia, some wow words of wisdom by anybody, delegates or faculty, please, I'm giving you 1 minute to do that. Otherwise, we will be ending the session. Tushar, any message from you? Any summary or take-home message from your side on these patients?
For one, I may just say that the plastic bowing of ulna with the anterior dislocation of the radial head is something which we still may fail to recognize in spite of knowing about it. And like I was discussing with you before the meeting, is that there are times where we may get a plastic bowing of ulna about 1 week down the line. So that time it requires a very aggressive approach. Otherwise, I think we have to individualize our approach to the montagia that we receive and decide for ourselves, for our patient.
So one of the questions by the audience, would it be possible without the distraction? And answer is no. Distraction and angulation, these are two essential components of treating any delayed presentation of montagia. And that's the way to start first. This was one of odd cases where this did not succeed in reducing the radial head. And that is when you suspect that there is something which is obstructing the radial head.
Sir, Sudhir here.
Yes,
Taral sir. Sir, actually, I had a patient who was 3.5-year-old girl, presented with around 6 months old montagia fracture, means montagia fracture. I tried to do distraction osteotomy. Somehow with difficulty I could reduce, because the soft tissue were very tight. I could reduce the head, but post-op, what happened that the patient developed ulnar nerve palsy.
Okay.
So, and the radial head was still remained dislocated after I removed the plaster. So anything which I could have done, because the soft tissue was really very tight. I did it, I knew it will dislocate, but I didn't have any other option at that time. I have to leave it, and it dislocated eventually, and patient developed ulnar nerve palsy.
So did it recover eventually?
Eventually, the ulnar nerve recovered, but the head remained dislocated.
Taral, in the trauma course, in this POSI, it was discussed that distraction more than about 10 millimeters will lead to ulnar nerve palsies.
Right.
That should be 7 to 8 millimeters should be the uppermost limit of distraction. You have to look elsewhere.
Absolutely. So there are limits to distract acutely, and one should really maintain those.
Maybe consider shortening of radius at that point of time.
So some points from which have come from the delegates and faculty, I'm just going to read out. Vidyasagar has a very important point. It says angulation also reduces the length in a way. So we need to distract to maintain the intraosseous length, a very, very important point. And Sunil has said that immobilization in hyperflexion and weekly x-rays are must, a very, very important point. Again, Sunil from Sri Lanka, we take those points. And Bansi is saying that flexion of 100 degrees during primary casting. Yes, it should be done, because that's the only way you are going to be able to relax the biceps tendon. And unlike supracondylar fracture, where hyperflexion, plaster, or immobilization is no, you can do it in a montagia without much of a risk. And Sandeep Vaidya has a comment that along with flexion, lateral ingulation helps in tense intraosseous membrane. Never tried it, but I'm going to try it sometime. So with this, I think we have reached 12:50, end of the time for this session, end of the time for this lovely meeting, 2022, the time which we are going to, cherish, though we were not able to meet personally. Dhiren bhai, this was a meeting where, this was meeting of minds and meeting of hearts. We really enjoyed this meeting. And what we really enjoyed is your experiment that everyone had to record and submit. And that is one sort of a rule which made this meeting go very smoothly. A hybrid sessions, where we had recorded sessions and then live discussion also went very well. These are the things for other meetings to follow all over the world. So with this, we end this session, and thanks the organizers for giving us opportunity to wind up POSICON to 2022. Thank you very much.
Thank you very much.
Yes, Rajiv, would you like to officially end the session, end the program?
Yeah. Thank you everyone for being here till time. At around 1 o'clock also, now we have around more than 100 delegates still watching our show. And I thank all the delegates, all the faculties, POSI, KOA, and I hope that everyone has enjoyed the academic feast. We missed out on the social gathering and probably Bhubaneswar, where we'll catch it up. So we'll now looking forward to Bhubaneswar. See you soon there. Thank you everyone again.
Thank you. Bye-bye. Stay safe.
Bye.
Bye.
Thank you.
Bye, everybody.
Bye.
Thank you. Thanks for the nice meeting.
Thank you, everyone.
Thank you, Ashok.
Thank you, Dhiren sir.
Yes.
Tell me when to end the meeting. So.
Yeah, but please end the meeting. I will stop the recording. Yeah.
Okay, sir.
So
Bye.
now 2 questions. How we will send this to Dr. Karne?
Does he want recording or does he want screenshot? Just be clear with that.
Okay. I don't know.
Because the MMC requires screenshots. They don't need.
So screenshots at the regular interval or?
It's just 2 or 3 screenshots here and there.
Okay, right. And then how about the list of participants? Do you
People
have
who
some
have
Excel
registered,
sheet?
we have the list. We'll send to them.
Yeah, no, like those who have registered for from the Zoom, you
Yes,
get the list.
only them. Only they will be considered.
Okay, right. So again, like when it comes to sending the certificate, we need to send certificate to only those who have registered on the Zoom.
That you can decide, sir.
Okay, right. Yeah.
So just one request from all of us is that make the recording of this conference available so that
we
we
will
can
do
go
it for
through
the POSI website. Yes, we will put
yeah,
it on
we can
the
do it
POSI
for
website.
yes.
Then we had another okay, I will discuss with that because posters can be uploaded on the website. That's not an issue.
I think so.
But what about the video technique? Because video techniques are long and they are really difficult to put. So
they will all be put on YouTube as we do with other videos. OrthoTV has done that. So we can ask Neeraj and Ashok to put it on YouTube channel of OrthoTV, and then we'll provide a link. So so anyone who wants to watch these videos, this can be done. So there was a suggestion, like for a lot of programs like Indian Idol, how there is a voting process. Ashok, if we can set up a voting process for the video session and announce a small prize, a lot of people will ask other people to visit their videos and vote. And the video and the most popular video at end of a month or so can get just a mention prize, a mention that this was the most popular video of POSICON 202.
Sure, I can do that.
No, we'll leave it to Dhiren Bhai and Rajiv and our committee to decide on.
Yeah, they can decide. Technologically, we can do that.
Right. Yes. And Rajiv, have you thought of anything about the certificate? Have you designed those certificates or something like that?
They were all ready. I mean, we with help of Vama, we were almost ready for printing.
Right.
And I have to just check whether some of them have already been printed, because we were just a couple of days ahead, and we were thinking that at least those delegates who are coming here, since we were not giving them any gifts or anything, we were thinking that at least we should give them the certificate physically. So I have to just check out whether some of them have been printed or what is the status, but the soft copies were already ready.
Okay, but like we need to write the name, and the second important thing is like please don't give certificate to all the registered delegates.
Yes.
We don't want to sell the certificate. We just want to give only to those who have participated in the program.
Yes.
Yeah. So just don't be very lenient.
Because
like
now we have to again see, sir, whether we have been granted 3 points and we had still applied for the 6 points. So we have to check out the status, and then we have to probably get a formal signature of the MMC observer also on that.
Yes. Yeah.
So
I think Dr. Abhyankar will be able to like coordinate all those things at the MMC and at the Maharashtra Orthopaedic Association level.
Yes, sir. We'll just take a couple of days of break and then we'll be back to work.
Yeah, sure.
Faculty, they had additional 1 point, I think, for all MMC this program.
Yeah, that later I haven't seen. It is with Dr. Abhyankar. Probably once we are again back to work in a couple of days, probably we'll sort it out.
And before like you start distributing the certificate or print the certificate, show us the design, like what is a material and what is what is a text and all that which is written in that.
Yeah. Okay.
Yeah.
Yes, sir. And sir, I just noticed yesterday but did not comment. Shakti has his own website, 2-3 probably. So
yeah,
that
so we
needs
will bring that to his notice.
yeah, because that was not brought yesterday. So just
sure.
Okay.
Yeah.
And yeah, we'll again continue to talk further, and probably will everything be okay.
Right. So have a good afternoon nap and then a good night sleep.
Thank you, Rajiv. Once again, congratulations.
Thank you, Rajiv.
Thank you.
Thank you.
Any
Bye.
special thanks to
Bye.
Ashok and Neeraj.
Thank you, Ashok.
Yeah. Thank you,
Ashok.
Mahek. Sorry, like at one point I was like to tell you that, yeah, I have stopped the video.
No
Big hand to
problem, sir.
Ashok and
It's all
Neeraj.
good, sir. No problem, sir.
Okay. Yeah.
Thank you. Yeah, bye.
Bye bye, Ashok. Neeraj.
Okay, Dhiren, bye bye.
Bye. Bye, Hitesh. Congratulations.
Bye bye. Thank you. Thanks.
Congratulations.
तो दे दो अभी
Bye bye.
पार्टी तो दे दो अभी
Sure,
Sandeep
sure.
Vaidya observed very thing that all the three base paper are Shahs. Hitesh Shah, Maulin Shah, Shalin Shah.
Right.
Yeah.
That's great. Chalo, congrats, Hitesh, once again.
Yeah.
Okay,
Bye.
Congratulations, Rajiv. Bye.
Thanks.
Bye.
I think few people are just logged in. I mean, they have forgotten that they have just logged in and went out. Okay, bye.
Yeah, Mike, I'm ending the meeting. You can also leave.
Okay, sir. Okay, sir.
Okay, thanks. Good show.
Thank you, sir. Okay, sir. Thank you, sir.